public health and safety and promote high quality and safe dental care by providing enforcement, licensing, peer assistance, and related information services to licensees and the patients. So a good reminder to us of our charge. Ms. Stutter, could you call a roll, please?
Dr. Brian Henderson.
Present.
Dr. Robert McNeil.
Present.
Dr. Kirsch.
Present.
Ms. Palermo.
Present.
Dr. Melcher.
Present.
Present.
Dr. Yu.
Present.
Dr. Tillman.
Here.
Ms. Jones.
Present, sorry.
Ms. Sisk.
Present.
And Mr. Bustamante is absent, but we have a quorum.
Thank you. Let me begin by asking for a motion to approve the minutes as written or as amended. I see a motion by Dr. Henderson, a second by Dr. Kirsch. Any discussion or corrections? Seeing none, Dr. Kirsch, how are you, sir? Well, let me call on Ms. Stutter to have a roll call.
I can do it,
okay.
Dr. Tillman.
Very good.
Yeah.
Very good. Thank you.
Okay, all in favor of the minutes, Dr. Tillman?
In favor?
Dr. Kirch, in favor. Ms. Palermo?
In favor.
Dr. Brian Henderson?
In favor.
Dr. David Yu?
In favor.
Dr. Robert McNeil?
In favor.
Dr. Linda Burke?
In favor.
Miss Lori Jones?
In favor.
Dr. Margot Melcher?
In favor.
Mr. Rodney Bustamante? Miss Catherine Sisk?
In favor.
The motion carries unanimously with the absence of Mr. Bustamante.
Very good. Thank you. I'll call on Ms. Stutter to lead the discussion on possible action on Emergency Rule 22, Texas Administrative Code 108.7, Minimal Standard of Care. Ms. Stutter.
Thank you, Dr. Tillman. The board's Emergency Rule 108.7, subsection 16 is set to expire on December 22nd. Pursuant to the applicable law regarding emergency rules, the board's options, we have two options, either to allow the rule to expire or extend the rule for another 60 days. If the board chooses to extend the rule, it will be effective starting on December 23rd and will remain in effect until February 21st of next year.
Very good. So do I hear a motion to extend the Emergency Rule 108.7 for 60 days? Dr. McNeil, second by Dr. Kirsch. Any discussion? Seeing none, Dr. Kirsch, could I have a roll call, please?
Yes, sir. Dr. David Tillman.
In favor?
Dr. Kirch, in favor. Miss Lois Palermo.
In favor.
Dr. Brian Henderson.
In favor.
Dr. David Yu.
In favor.
Dr. Robert McNeil.
In favor.
Dr. Linda Burke.
In favor.
Miss Lori Jones.
In favor.
Dr. Margot Melcher.
In favor.
And Miss Catherine Sisk.
In favor.
Mr. Rodney Bustamante, I'm assuming is still absent from our meeting. Is that correct?
Correct.
Do I need to call on him every time, even though I know he's absent?
That would be helpful, just to keep Mr. She doesn't have a screen, just to make sure she realizes that he's not here, and to kind of, if possible, sir, please. Thank you.
Perfect. That's fine. So we have a unanimous carry of the motion again.
Thank you.
Point of order?
Yes.
Have we established that the live stream is functioning before we get on much further?
So Mac is functioning. I'm kind of using secondary devices to kind of follow things, but
the live stream is functioning, Dr. McNeil.
Yes, I got confirmation as well.
I did too. Yeah.
Yeah, mine keeps kicking off. So anyway, a great settlement orders. Ms. Stutter, could you lead the discussion on possible action on proposed case resolutions?
Yes, so the agreed settlement orders are in your materials, and board staff asks that you approve the orders as presented.
So do I have a motion to approve the agreed settlement orders as presented? I hear a motion by Dr. Keir, second by Dr. Yu. Any discussion? Seeing none, Dr. Kears?
Dr. David Tillman?
In favor?
Dr. George Kirch, in favor. Ms. Lois Palermo?
In favor?
Dr. Brian Henderson?
In favor.
Dr. David Yu?
In favor.
Dr. Robert McNeil?
In favor.
Yes, thank you.
Dr. Linda Burke?
In favor.
Miss Lori Jones?
In favor.
Dr. Margot Melcher?
In favor.
Mr. Rodney Bustamante is absent. Miss Catherine Sisk?
In favor.
The motion carries unanimously.
Thank you, Dr. Kears. Next, remedial plans. Do I hear a motion to approve the remedial plans as presented? Dr. Henderson, I see a motion, and Ms. Jones, a second. Any discussion? Seeing none, Dr. Kears.
Dr. David Tillman?
In favor?
Dr. George Kirch, in favor. Miss Lois Palermo?
In favor?
Dr. Brian Henderson?
In favor.
Dr. David Yu?
In favor.
Dr. Robert McNeil?
In favor.
Dr. Linda Burke?
In favor.
Miss Lori Jones?
In favor.
Dr. Margot Melcher?
In favor.
Mr. Rodney Bustamante? Miss Catherine Sisk?
In favor.
Again, the motion carries unanimously.
Thank you, Dr. Kears. Agreed administrative penalties. Do I hear a motion to approve the agreed administrative penalties as presented? Dr. McNeil, and I see a second by Dr. Burke. Any discussion? Seeing none, Dr. Kears.
Dr. David Tillman?
In favor?
Dr. George Kirch, in favor. Miss Lois Palermo?
In favor?
Dr. Brian Henderson?
In favor.
Dr. David Yu?
In favor.
Dr. Robert McNeil?
In favor.
Dr. Linda Burke?
In favor.
Miss Lori Jones?
In favor.
Dr. Margot Melcher?
In favor.
Mr. Rodney Bustamante? Mrs. Catherine Sisk?
In favor.
The motion carries unanimously again, Dr. Tillman.
Very good, thank you. Consent orders. Do I hear a motion to approve the consent orders as presented? Did you have anything, Ms. Studdard? I probably should have called on you.
No.
Okay, good. So do I have a motion, Dr. Yu with a motion and Dr. Henderson a second? Any discussion?
That was Dr. Yu that made the motion.
Dr. Yu made the motion, Dr. Henderson seconded. Thank you. Dr. Kears.
Dr. David Tillman?
In favor?
Dr. George Kirch, in favor. Miss Lois Palermo?
In favor?
Dr. Brian Henderson?
In favor.
Dr. David Yu?
In favor.
Dr. Robert McNeil?
In favor.
Dr. Linda Burke?
In favor.
Miss Lori Jones?
In favor.
Dr. Margot Melcher?
In favor.
Mr. Rodney Bustamante? And Mrs. Catherine Sisk?
In favor.
The motion carries unanimously.
Very good. Thank you. Ms. Studdard, now we'll let you lead the discussion on pre-IOC recommendations and proposed case resolutions.
Board members, board staff ask that you approve the pre-ISC recommendations of dismissal as presented.
So we have a recommendation. Dr. McNeil, is that a motion to accept?
I wanted to pull one case.
Thank you. Could you list the case by number?
Yes. 2019-01141.
Okay, we got that?
Yes.
Perfect. So do I hear a motion? Dr. Henderson.
Yes, I'd like to also pull a case.
Thank you.
2019-00998.
Very good. Any other cases to be pulled? So do I hear a motion to approve of the amended resolutions, case resolutions?
So moved.
Kirsch, and second by Dr. McNeil. Discussion. So seeing none, Dr. Kirsch.
Dr. David Tillman.
Approved.
Dr. George Kirch, in favor. Ms. Lois Palermo.
In favor.
Dr. Brian Henderson.
In favor.
Dr. David Yu.
In favor.
Dr. Robert McNeil.
In favor.
Dr. Linda Burke.
In favor.
Ms. Lori Jones.
In favor.
Dr. Margot Melcher.
In favor.
Mr. Rodney Bustamante. And Ms. Catherine Sisk.
In favor.
Motion carries unanimously.
Very good. Thank you. Do we want to proceed or should we address this?
In executive session.
Okay. So do I hear a motion to go into executive session to discuss these cases? Dr. McNeil, second by Dr. Henderson. If you could, by raising of hands, in favor of the motion, that's Dr. Margot, Ms. Jones, Dr. Henderson, Dr. McNeil, Dr. Burke, Ms. Palermo, Dr. Yu, Ms. Sisk, Dr. Kirsch, and Dr. Tillman are all in favor of the motion. That's unanimous. So we will go into special executive session. I have 8:50 a.m. Thank you. So,
and if board members could please click on the breakout room link that is coming up in just a second here.
Wait on it. Wait on it. Okay.
Perfect.
Okay, is everybody on? Very good. So I'll call us back to order. I have 8:58 a.m. So
Repeat that.
I have 8:58 a.m. We are back in session. Thank you. Do I have a motion to for how to deal with these cases? Dr. McNeil.
Dr. Tillman, I would like to make a motion to have two case numbers, number 2019-01141 and 2019-00998, both referred for a informal settlement conference.
Very good. So I have a motion to refer to our informal settlement conference, and I have a second by Dr. Henderson. Any discussion? Seeing none, Dr. Kirsch.
Dr. David Tillman.
In favor?
Dr. George Kirch, in favor. Ms. Lois Palermo.
In favor?
Dr. Brian Henderson.
In favor.
Dr. David Yu.
In favor.
Dr. Robert McNeil.
In favor?
Dr. Linda Burke.
In favor.
Ms. Lori Jones.
In favor.
Dr. Margot Melcher.
In favor.
Mr. Rodney Bustamante. Mrs. Catherine Sisk.
In favor.
Dr. Tillman, we have a unanimous carry of the motion.
Very good. Thank you. Ms. Stutter, post-ISC recommendations of dismissal, proposed case resolutions.
Staff asks that the board members approve the post-ISC recommendations of dismissal as presented.
Very good. So do I have a motion to approve the post-ISC recommendations of dismissal?
So moved.
Thank you. And I need a second, Dr. Burke. Thank you. Any discussion? Seeing none, Dr. Kirsch.
Dr. David Tillman.
Favor?
Dr. George Kirch, in favor. Ms. Lois Palermo.
In favor?
Dr. Brian Henderson.
In favor.
Dr. David Yu.
In favor.
Dr. Robert McNeil.
In favor?
Dr. Linda Burke.
In favor.
Ms. Lori Jones.
In favor.
Dr. Margot Melcher.
In favor.
Mr. Rodney Bustamante. Mrs. Catherine Sisk.
In favor.
We have a unanimous carry of the motion.
Very good. Thank you, Dr. Kirsch. Ms. Sutter, post-mediation recommendations of dismissal. Could you lead the discussion on possible action on proposed case resolutions, please?
Yes, sir. This case, it's one case. It was set on SOA's mediation docket. The board member who attended the mediation recommended a dismissal of the case, and you will see that memo in your materials. Board staff asks that you approve the recommendation as presented.
Very good. So do I hear a motion to approve the post-mediation recommendations of dismissal?
So moved.
Thank you, Dr. Kirsch, and a second by Dr. Henderson. Any discussion? Seeing none, Dr. Kirsch.
Dr. David Tillman.
In favor.
Dr. George Kirch, in favor. Ms. Lois Palermo.
In favor?
Dr. Brian Henderson.
In favor.
Dr. David Yu.
In favor.
Dr.
Sorry.
Robert McNeil.
In favor?
Dr. Linda Burke.
In favor.
Ms. Lori Jones.
In favor.
Dr. Margot Melcher.
In favor.
Mr. Rodney Bustamante. Mrs. Catherine Sisk.
In favor.
We have a unanimous carry of that motion.
Very good. Thank you, Dr. Kirsch. Modification.
You're welcome.
Ms. Stutter, could you lead the discussion on possible action on proposed case resolutions? And I'm talking slowly because it's going to be just a second.
Sorry, Dr. Tillman.
Oh, you're good. Apologies.
If we could go back to the pre-ISC recommendations of dismissal, it was noted that the board members, we need to make a motion to approve the batch of recommendations that weren't pulled. I don't think that was here.
We did make that motion. After we pulled them, we made that motion and it carried.
Yeah, we pulled them, then we made the modified
Yes,
We approved that at the time, and then we came back to the other two.
that's exactly right.
I think that's on the record. So I think we're good.
Okay.
Yes,
Very good. Okay.
I agree.
Very good. We are back online. Ms. Studdard, modification orders, proposed case resolutions.
There is one modification order for your review, and board staff asks that you approve the order as presented.
Very good. So do I have a motion to approve the one modification order? Dr. Yu, in favor, and do I have a second? Dr. McNeil. Discussion on this case. Seeing none. Dr. Kirsch.
Dr. David Tillman.
In favor.
Dr. George Kirch, in favor. Ms. Lois Palermo.
In favor.
Dr. Brian Henderson.
In favor.
Dr. David Yu.
In favor.
Dr. Robert McNeil.
In favor.
Dr. Linda Burke.
In favor.
Ms. Lori Jones.
In favor.
Dr. Margot Melcher.
In favor.
Mr. Rodney Bustamante. Mrs. Catherine Sisk.
In favor.
The motion carries unanimously.
Very good. Thank you, Dr. Kirsch. Do we
You're
have
welcome.
specific orders?
We do not.
We don't have any specific orders, so we'll continue. Ms. Studdard, could you lead a discussion on possible action on cases heard before SOA, the State Office of Administrative Hearing?
Yes, we have one case. It was docket number 504-21-0415 regarding Casey Morrow, registered dental assistant number 39182. All the materials are uploaded, including the judge's proposal for decision, as well as board staff's recommendation. Also included in your materials was a supplemental letter provided by the respondent for your review. She did not attend the hearing, but she did provide some supplemental information for you. Ms. Sonia Subash was a staff attorney who was assigned to this case, and she will present the board staff's recommendation.
Good morning.
Good morning. Okay, this case was set for a hearing on December 2nd, 2020. The proposal for decision by summary disposition was issued on November 18th, 2020. No exceptions were filed. Staff recommends that the board move to adopt the order of the board as attached and revoke Texas Registered Dental Assistant number 39182 issued to Ms. Casey Morrow.
Very good. Thank you. So in light of that, do I hear a motion to accept the staff's recommendation to adopt the order of the board here? Dr. Yu.
So moved.
And Dr. Kears, a second. Any discussion? Dr. McNeil.
You know, I'm certainly speaking in favor with the motion on the table. Part of the changes we made to the disciplinary matrix to reflect certain legislative rules and regulations that we had to have meshed together. We don't have a whole lot of options here. And
right.
This individual gave a pretty impassioned letter to us with some of the great work that she is doing as part of recovery, but our hands are tied on this.
Yes, not a fun part of the job, but again, our charge is to protect the public, and I think this does that. So thank you. Any other comments? Seeing none. Dr. Kirsch.
Dr. David Tillman.
In favor.
Dr. George Kirch, in favor. Ms. Lois Palermo.
In favor.
Dr. Brian Henderson.
In favor.
Dr. David Yu.
In favor.
Dr. Robert McNeil.
In favor.
Dr. Linda Burke.
In favor.
Ms. Lori Jones.
In favor.
Dr. Margot Melcher.
In favor.
Mr. Rodney Bustamante. Mrs. Catherine Sisk.
In favor.
Dr. Tillman, the motion carries unanimously.
Very good. Thank you. Presiding officer's report. Herb. Ms. Jones.
Yes, thank you. I attended the HERB meeting in October for REB. And as you can see in the packet, that's the minutes from the meeting. And I just wanted to highlight just a few things. One is that, as we all know, they developed the dental hygiene OSCE exam. that was taken by many of our students. So that was the written exam. They do have a new dental mannequin exam base that will be coming out in 2021. And there's two parts to it. It'll be an assessment over the perio, and then, and then the second part is the removable calculus part of the exam. They also partnered with an organization or company called Test Run, and that is a group that helps people prepare for the exam with practice tests over the structure of the exam. So candidates have up to 90 days prior to the exam to take it as many times as they want to make sure they feel comfortable with the exam that's coming up. Then we also had each state report over what's going on in their state. And one of the interesting things I found is that a lot of the, well, I can't say all, but majority of the states were actually going back to put into their rules a live patient component for their clinical exam. So it was interesting to hear from around the country what different states were doing. So that's my report.
Very good. Any questions for Ms. Jones? Thank you. We appreciate your representation. Some credits. Is she here?
Yes, I can almost say ditto to Lori's. I guess you have in the packet or sent out the states that are within credits and the hygiene part of the exam, since I'm on that hygiene review committee for them. I don't really get the dental part of it because it's just the hygiene exam part, but it did look like a majority of them were going back to the live patient exam after the end of the year. So it'll be interesting to see what happens. And also, I think, if I'm not mistaken, their executive director just resigned as of November 1st. So Kimber Cobb will not be the executive director anymore on that. They did just start a pilot on their mannequin-based exam, and it'll be interesting to see what kind of data they have coming out of that. So I'll keep everybody posted when that comes out. And we don't have a meeting again until next summer, I believe. So that's where we stand with credits.
Very good. Any questions for Ms. Palermo? Thank you again for your representation, Ms. Palermo. Dr. Henderson, do we have anything, sir, from REB or from the ADB?
Yeah, it's actually a couple of things. The AADB meeting is in February. It's a virtual meeting, and Wendy has that information if you would like to participate for the AADB meeting. We had a DERB meeting on November the 14th that is submitted in the minutes, and rather than in your packet, and rather than go through it all, I'm just going to hit a couple of highlight things. It was kind of an interesting year for REB. They gave, about 30 exams, 29 exams. Pass rate on the mannequins were very similar to what they've always done in the past. In 2021, a couple of new things from REB. One is they're going to weight the CTP in a little bit different fashion. Second, REB is really pushing the member states that dentists maybe shouldn't be required to do the perio section. They feel that the dentists delegate the perio to hygienists, and that it really is a function that dentists no longer perform. Therefore, it's not really showing any results. However, as you see in the state's reports, those that are removing it and those that are adding it or keeping it is in your deal. And rather than go through the member states and deciding what that was, I found that an interesting deal. The new REB mannequin exam, it's going to be a mannequin exam again this year. The teeth are going to be very natural-like. They're going to have a DJ and enamel and dentin section. There's going to be a pulp involved. So if a student did that as opposed to just the plain ivory teeth that were there last year, the teeth actually have decay models in them, and they're going to be variable. Students that want to practice with those similar teeth are available, but the actual exam teeth are restricted to the exam only, and those are all based on natural teeth. The other really interesting thing that they put in there is REB is now doing a dental therapy exam for those states that are licensing dental therapists, which we not do. And that's basically it. Does anybody have any questions regarding the REB? Yes, Dr. McNeil.
Thank you, Dr. Henderson. Was there any talk with the member states at either putting an asterisk on a given license during the pandemic where they were not able to have live patient exam, or necessitating a retake of an exam once COVID is over and live patients can be utilized?
Well, that discussion really wasn't probably germane to REB because they don't give the license. The license comes from the states. But I will tell you, I have heard from a number of students that graduated last year that took our CTP as their perio section, and now they're going to a state that does mandate a live perio or having to take that section. They're not honoring that as a license, even though they have a Texas license. This year, what's interesting about REB, because of their policy with the perio, they do have the mannequin-based perio with the calculus that Ms. Jones was talking about that they have for hygiene for dentists as well. But they're also considering using the CTP as a perio section. And so I'm not sure which way the state of Texas is going to be examined as far as their perio concept. Yes, Dr. McNeil.
A follow-up on that, is the perio simulation that has not been utilized yet for REB, but that's for the next upcoming set, is that correct?
That's correct.
Okay.
That is for the 2021 tests.
Very good. Thank you, Dr. Henderson. Any questions? Any further questions? Yes, sir. Go ahead. Seeing none, continue, please. Dr. Henderson, go ahead.
I have nothing else. Thank you, Dr. Tillman.
Thank you, sir. And we appreciate your representation on these bodies. This is a dynamic time on our examinations, and we appreciate you staying up on everything and keeping us informed. Thank you. Okay, we did have, it's not on the agenda. I'm not required to respond, but we did have something brought up in committee yesterday. I just wanted to and get verification from Ms. Studdard. Vaccination of the COVID is not under the scope of practice for dental practice. Is that correct, Ms. Studdard?
That's correct.
So we had a discussion about that. Just want to verify and send that word out to our clinicians. Yes, Dr. McNeil.
So just a clarification on that. Is it correct in what I hear you saying is that a dentist should not be providing a COVID vaccination for their patients?
At this point, correct.
And then I'm going to take the question a little bit further. Can they provide vaccination for their own staff members?
Oh, again, yes, Ms. Studdard is shaking her head no. So now the other question you might have is the MD part of our, I'm not going to comment on our oral surgeons that are MDs. That would be a different matter, but this is as it relates to the practice of dentistry. Any other questions related to that? Thank you.
One question. Sorry.
Yes, for you.
Well, and the only way we can change that just for stakeholders is, legislative mandate or governor's order to allow dentists to do it. I know North Carolina, for instance, has been, I think Oregon actually has been working on that, and they're allowing dentists to vaccinate. So certain states are doing it, but right now it has nothing to do with the board.
Very good. Dr. McNeil.
And
yes, Ms. Studdard.
Since this isn't a topic of discussion on the agenda, I don't want us to go too far.
Thank you. Thank you. Okay. And that's all I have to report. Again, hopefully next time we will be together in person. As the governor sends out recommendations, we will follow them. But we want to protect our staff at the state board as well as each other. And so we're following his directive, and we will see what the future holds. That's all I have to report. Professional recovery, PRN.
Yes, we have a representative from PRN, Abraham, who is going to be presenting his report to you.
Do we have? It's joining. He is joining. There.
He can hear us. We're just waiting for him to enable his audio.
Okay.
Okay. Welcome, sir. Good morning. Can you hear us?
He needs to enable his audio.
I don't think he can hear us.
He didn't have his audio enabled.
Please, sir, if you could, well, he's connecting. Very good.
Can y'all hear me now?
Very good. Yes, we can, sir. Welcome. We appreciate you coming before us.
Can you hear me?
Yes. Yes, we can. Can you hear us? He can't hear us. Go ahead, sir. You can lead our discussion on PRN if you can hear us.
I can hear you.
Can somebody contact him and tell him to go ahead and just give us? Okay. Board, you do have a report from PRN. You could be looking at that as well. Yes, Dr. Yu.
Well, while we're trying to connect with Abraham, I was one that asked Abraham if he could kind of do a summary for us on the intake of patients to PRN. And I also wanted to thank Abraham for his service because the previous director, Eden, left and he took over, but he's going to turn the reins over to a new person. Her name is Patty Dodson. So thank you, Abraham, for your service to PRN.
Hello?
Yes.
There he is.
Can you hear us?
Hello?
Hello, sir. Can you hear us? We can hear you.
Meetings are brutal.
He's still not hearing.
Not much we can do.
Yes, somebody could call him. We could just get the audio, perhaps.
No phone number was provided.
I have one.
Ms. Capel has. So Ms. Capel is going to try to connect with his phone and just get the report by phone. We're having some difficulties. Dr. McNeil.
Just to talk about that report that they sent, one of the things that I like that they've been able to do during the pandemic is sort of rely a little bit more on telecommunication modalities. I think one of the challenges that we would hear a lot that licensees would have a hard time sort of getting to a therapist or a counselor, for instance. And I think being able to use video conferencing has been a pretty big asset for people to get the care that they need. So that's certainly a positive out of what we're going through right now.
Right.
Chris, he said he has audio on phone. Can you get him on the phone?
All right. So go ahead and rely on. Do you have his phone number, or should we try?
Okay, let me get it.
Letitia.
He didn't answer, did he, Letitia?
He didn't answer.
Let me get a good phone number.
It's not answering the chat message either.
Dr. Tillman, I believe Dr. Henderson has a question.
Yes, Dr. Henderson.
Dr. Tillman, is it a possibility, since we are at this technical situation, we can let them continue to work on this and we move on the agenda?
Very good. So let's have we've had a discussion on DERB. Have we not?
Yes.
Okay. So I think we're good on that. Licensing committee report. Dr. Pierce, are you prepared to bring your report?
Yeah, can you all hear me?
Very good. Yes. Go ahead, sir.
Can you all hear me now?
Actually, that's Abraham.
Yes.
Yeah. Sorry about that.
Stop the shift. Let's go ahead. Welcome, sir.
Well, welcome. Sorry about that. I was trying to make sure that we didn't have any hiccups, and there we go.
There we go.
Okay. So my name is Abraham Minhades. I'm currently the director of PRN. I sent some information. One is a report that's pretty much structured exactly like Eden, the previous director, was presenting to you. I also added a PRN presentation. Dr. Yu had reached out to me and asked if it was possible kind of go over the steps of what a participant would go through if they're coming through PRN. So I went ahead and did that. What I'd like to do, though, I know I've already eaten into a lot of my time, so I was only going to hit the highlights from the report, then go into the presentation. Would that be okay with you all?
Take your time, sir.
Be perfect.
We're good.
Okay. So let me just talk about a couple of things that I think are relevant here. You obviously can read, so you can read through the rest of it. But we did have a seminar, the fall seminar. Again, it's via Zoom. Fall seminars with PRN, if you don't know, tend to be in person. But of course, with COVID-19, that's just not possible. But we had a fall seminar on October 30th. I thought it was a really well-presented topic, which is hope and despair and addiction. So the presenter, Mr. Hilliker, did a great job. And I just kind of want to highlight that because I thought it was a great presentation. And we had a really good turnout from our participants across all 4 boards. Next, I want to talk about the performance audit. So as you might know, every September, PRN has an audit for the previous year just to determine if what we're doing is making a difference. And I want to kind of go over that a little bit. So the highlights here, again, the actual sample for that audit was a total of 52 individuals. And this is dentists, of course. This is not the total PRN caseload. So it's 52 dentists, dental hygienists, and assistants. And what we had, or we found from that audit was, so the recidivism rate for fiscal year 2020 was 0%. And again, what that means, that's a 3-year rate. So 3 years post 1 year, if they have not relapsed, that's what we're looking at. There was 0% of relapse. And then our 1-year completion rate was 62.5%. And again, that's individuals in the first year who have relapsed. Any questions about this data here? I know that it's been presented, it gets presented every year. I just want to make sure if there are any questions related to that.
Yes, I have a question. On your 1-year completion rate is 62%. The 40% that don't complete in 1 year, where do they fall in?
Well,
typically?
I mean, basically what that means is they have a relapse, right? So within the first year, they've relapsed in some form or fashion. And we continue to work with them. It's not like they fall out of the program. This is just really just kind of trying to figure out, okay, you know, are we able to try to keep the participants sober and clean in the first year? Obviously, we can't totally control that. So what that just means that, yeah, 40% unfortunately relapsed. So we continue in the program, continue to work with them.
Well, the reason I asked that is that I wondered, of that 40%, could you ever is there a tracking that those 40% then end up being a 3-year success rate? Do we know that data?
Yeah, absolutely. And again, I don't know on the individual basis, but exactly. So if they relapsed, but then 3-4 years later, they have stayed clean and sober, that goes into that data. So once again, when the auditor comes to audit, we're looking back in time. So it's totally possible that somebody who relapsed early in their participation with PRN has remained clean and would fall into those numbers.
So the numbers that we're looking at exclude that 40% because you got 62% and 0%. I just wanted to make sure I'm not missing that.
No, you're correct.
Okay, thank you.
Yep. Any other questions related to the audit?
Thank you again, Mark. The assumption is with COVID that there was an uptick of cases, a lot more stressors out there financially, probably maritally, within the practice. Have you seen that, and is that continue to increase, or is that leveling, or where are we as far as new cases and actions with the PRN?
Well, in my stay here, I haven't seen, so again, I'm speaking for the last couple of months, I haven't seen a big increase, but we do know that just everybody sheltering in place and all that the use of substances across the board, right, across the general population has gone up. We know that anecdotally, and I'm sure there'll be research that's going to come out that's going to show that number. So I haven't seen an increase from dentists right now, but what I will say is my guess is, probably in the next several months, we're going to see probably some of those numbers start to tick up.
Dr. Yu.
Yeah, thanks for your great work, Abraham. I know we talked about the number enrolled, and what concerns me is the number of case managers. I know you guys have, 3 full-time case managers, and that winds up being about 50 to 60 cases per manager. Right. Are you looking at adding more soon? Because I know they're overwhelmed as it is.
So not right now, we're not. I can again, this is my experience working with a case manager. So what I would say is that there are 3 full-time case managers working cases. The director, though, is, also a part of that team. So although there's a lot of other things the director is doing on a day-to-day basis, they do and have taken cases on before. If the numbers go up, that would make it difficult for the current case managers to manage the cases. One thing I will say to you, though, so, even if we're saying 50, 60 individuals on a day-to-day basis, and these numbers attest to that, 50 to 60 people are not, in some kind of jeopardy. Majority of them are doing what they need to be doing, submitting the paperwork they need to be doing. So what the case managers are doing on a good day is just making sure that any data that they need to enter into the system we use, which helps us track all this, making sure they're compliant, making sure their tests are good, and or working with individuals that are having difficulty at that particular time. So I will say that it's a busy day, but I haven't seen where I would think that it's beyond what anybody can handle. If we got to that point, or I had already seen that, believe me, I would have already been talking to Debbie Garza, the CEO for Texas Pharmacy Association, about trying to increase the numbers. Now, to that, I will also say this. We have and are going to increase the monitoring fee. Currently, it's at $600 for the majority of folks that started prior to 2020, up to $750. Now, part of that is to try to make sure that we also have the finances. If we need to increase case management, we can do it with that. So that monitoring fee has been static for going back probably 15 years, and that's as far as I could find records that we had stored. So, again, it's been a long time overdue. We've kind of done our due diligence to make sure that we let participants know that would be affected and everyone else in the advisory committee and so forth. So to your point, Dr. Yu, I think right now I don't see, that the load is too much for the case managers. However, with the increased monitoring fee, if, we feel like we need to add another case manager, at least we would have the financial wherewithal to do that.
One more question, sorry. I thought the monitoring fee went from $650 to $700.
No, it's $750.
Okay. So, but that's
Yeah.
a yearly fee, right?
It is yearly, correct.
Okay, so that's a
Yeah,
modest
and just so the board,
increase.
right. Let me speak to that because I think this is important. So again, if the participant wants to pay it all up front, they can do that. If they want to break it out monthly, they can do that. If they start having difficulty, we'll work with them, and we're working with a number of participants. What we ask though is that they are contributing something, right? Not just throwing your arms up and saying I can't give you anything. So I just want y'all to know, we know these are difficult times. So we'll work with any participant that's having an issue paying it. We just need them to make sure that they're not abandoning it, that they are paying something. And the majority of the participants, again, are able to do it, and they do it on a monthly basis. And the increase, I think, will be just an increase of $12.50 a month. Yeah. I think that's what I worked out.
I think $62.50 a month is like a cell phone fee. It's worth their health. Yeah. Being. Thank you.
Well, exactly. And let me just kind of underscore that. What because I've talked to a couple participants about that, and what I've said to them is that this is your life, right? This is about not just your license, but your life in general, because we all know that you continue abusing substances or untreating your mental illness, that it literally shortens your lifespan. So I try to kind of preface it that way so they understand that this isn't just a program trying to take money from them, but it's a program that's trying to get them to a place where they're going to live longer.
Yes.
Any other questions about the audit?
This is Dr. Melcher. Good morning.
Good morning.
As far as I know you stated in your report that y'all had to go online for the sessions. In your personal opinion, do you feel that is as effective, or do you feel like you've had to make some modifications to it in order for the program to be successful?
I think face-to-face is always best, even if you're getting information. I think though, even before the pandemic, so many of us have already been using online resources like Zoom or WebEx. So I think that it provides a medium to pass information. So for instance, the seminar we had in October, I thought the presenter, again, he was on video, he did a great job, he had information. So I think as far as passing on good information that our participants can use to help them in the recovery, I don't think that it's been hurt dramatically by being online. What I believe is probably what we've lost the most is that my understanding is that both participants and PRN staff really enjoyed getting to put faces to names when they would see individuals in the fall seminar when it was face-to-face. So I think that has been lost, obviously, just kind of that personal connection. I know we try to tell participants that, again, we're not here to be friends, but we're also not here to try to catch them doing something wrong or somehow, hurt their chances of getting their license reinstated or keeping their license. It's all about advocacy. So I think that that's probably been the biggest downfall of not being able to have this face-to-face, is just being able to form that personal connection with some of these participants that we hear on the phone and know by name, but maybe haven't spoken to directly.
Very good.
Thank you.
Okay, just real quick with the LBB numbers, I sent these out yesterday. So board order dentists of 14, volunteer dentists 18, board order hygienist 2, volunteer hygienist 1. So those are the numbers as of the end of the first quarter of fiscal year 21.
Very good.
Okay, let me go on real quick to then just the process. I'm going to be really brief here. So a reminder, everybody's treatment plan and everybody's experience with PRN is individualized. So I'm going to go over just some of the big steps that everybody has to go through, but just understand that there are a lot of individualized treatment plans. So I want you to think that this would be identical for everybody when we get to the treatment side, at least. So first of all is referrals. Again, you can refer yourself. Somebody that loves you or cares about you can refer you, or the board can refer you to us. When we get a referral, we set up an intake pretty much within 24 hours. Confidentiality, I think this came up before because I saw it in something. So let me just really quickly talk about this. This is all confidential. So if a dental professional refers themselves to us, again, we're keeping that confidential. The exceptions, I'm not sure if you're looking at the slides, are if for whatever reason the participant decides, well, I don't want to do this anymore, but we know that they're continuing to use or their mental illness is getting worse and they're not taking any action to resolve it, and we think there might be a safety to practice issue, we would then break confidentiality. If the board has ordered them to participate in PRN and now they're not wanting to do that, we would break confidentiality. But other than that, if they come to us and say, I need help, we're going to work with them and we'll keep it confidential until we get to a point, if we get to a point where we can't do that. All right. Intake. So once we get the referral, within 24 hours, we call them and we do an intake. And again, the intake is just to get some basic information, to get an idea of, what might be going on with this participant. And then we refer them to an evaluator. So we've got a list of evaluators throughout the state that we use, and even some out of state for anyone that's trying to do reciprocity. And we vet the evaluators very closely because we expect that their report back to us meets certain guidelines. So again, we have, I think it's a pretty robust list, but it's not just anybody can be an evaluator. We're looking for those that have experience working with professionals and are willing to abide by our requirements as far as the report back to us. Any questions so far with what I've gone over?
Yes. So once they begin the process, once the ball starts rolling, is there like a contract or a signed document that binds you and the clinician or the participant?
There is a contract. We call it a service agreement, and that doesn't come into play in the process just yet. So we get the call, a referral, we have the intake with them, we send them to the evaluation, which we pay for the first evaluations on us. And then once the evaluation comes back to us with all the recommendations, because mind you, and I've seen this happen in my short stay here, where an evaluator said, yeah, this person has an issue, but he's got all the right treatment options, and PRN is maybe recommended for a year. Sometimes maybe not even recommended. So again, we don't want to have an agreement until we know that they need to be part of our program. Now, if the board is ordering them to us and we send them to an evaluation and the evaluator says, I don't think they need to be in PRN, obviously we're giving the board that information. But our service agreement, which we call it a contract, if you will, we kind of get that rolling after the evaluation comes back, and if the evaluator determines that they really should be part of the PRN program.
But say there's a self-referral. We would not, as a board, hear about that. Y'all would just work together unless there's a violation of the the steps to improve. Is that accurate?
That is accurate. So if I were to refer myself to PRN, I'm a dentist out there and I'm having some serious issues, not being able, abusing substances. If I'm complying, if I call in, I go to the intake, I go to the evaluator says, yeah, you have a diagnosable problem and you need to be part of PRN, and I say, you know what, forget it, I've changed my mind. Then that can be one of those circumstances where we're notifying the board. Now, mind you, the evaluator on their evaluation will tell us, you know what, I think this person, if they're not getting treatment and not participating in the program, could be a problem practicing. Then, that's kind of where we would, get involved and say, we're going to have to notify the board just for safety issues. But otherwise, other than that, again, we wouldn't say anything. It'd be confidential. So let me touch on support agreements real quick. So I'm skipping some slides here. Most of the support agreements last 5 years. So once the evaluation comes back and we go over it with the participant and say, this is what the evaluator found, this is what they're recommending, and everybody's in agreement they're going to be part of PRN. They sign the agreement, and most of them are 5 years, but there's differences. Like I mentioned, one was for 1 year. And if they're going through their 5 years and they have problems, they're relapsing, it could be extended. But for the most part, 5 years is on average what's the length of the support agreements. There is a yearly monitoring fee. We just kind of talked about that. They have to participate in all the treatment recommendations. And, even if the evaluator recommends that they're going into inpatient treatment, they have to make sure that they're going to do that. So once they're out back, so say that they either go to treatment or don't have to go inpatient, they are expected to be attending AA meetings. And it's the evaluator's recommendations again, and this is kind of why we vet them very closely. They're very detailed on what this dental professional needs to be doing. So there are no surprises both on the participants' end, on PRN's end, and if they're board ordered, and the board also knows exactly what needs to happen with this particular individual. And they're expected to obviously follow through on that. And if they don't, that's when we get into compliance issues. And most people sometimes, they stray a bit, but we get them back where they need to be going and we move forward. If we can't get there, then, again, we kind of loop back to, working with the board and trying to make sure that everybody's safe. Random drug screens. So that, again, that is really random. I'll tell you right now, they're on cycles. So some individuals, they have to check in daily, call in every day to find out if they're have been selected for a drug screen that day. If they don't make that screen, we know about it. If they submit and it's not a good test, we know about it. If they're positive, we know about it. So the system we use, Recovery Track, is really, really robust in giving us that information on pretty quick turnaround. So we'll know if a participant is not doing what they need to be doing related to their testing. Non-compliance, again, I kind of touched on this already. If they're volunteered and, they're coming back with positive drug screens, we have an option to go to a peer support committee. So if I'm a peer volunteer and I come back positive for one of my substances of choice, PRN can go to this peer support committee and basically presents it de-identified, so they're just seeing the basics, they don't know who it is. And if the peer support committee comes back and says, we think you should, we don't have to, you shouldn't report them to the board, let's keep working with them, or this person should be reported to the board. If they're on a board order, we notify the board that they've had a positive. Of course, we still work with them, but at that point, we need to make sure that everyone's aware of what's going on with them. I skipped some slides. I've sent Lauren a new set of slides because, unfortunately, there's a new director going to start on Monday. I put her information on the slides, so if any of you have any questions, if it's today, you can send them to me and I will respond. But starting Monday, you can send it to Patricia Dobson, and she can follow up on anything that I've presented today.
Very good. Any other questions? Again, thank you for your work. Very important area, especially these times. And we appreciate you and all the best in the future. Thank you.
Thank you so much. And I apologize for the audio difficulties.
No worries. Have a great week.
Appreciate it.
You too. Take care.
Okay. Very good. Back on track. Licensing committee. Dr. Kirsch.
Okay. Yes, sir, Dr. Tillman. I'm ready. Thank you. And I want to thank my committee members, Ms. Lois Palermo, Dr. Melcher, Dr. Burke, and Dr. Tillman and Ms. Sisk. They were prepared and engaged as always, and I appreciate it. We started off the meeting with a discussion of the CDCA by Dr. Champagne and Ms. Overfelt, and they gave a very nice, compelling presentation of their testing. They've been around since 1969. They do components of live patient and mannequin-based. They've got a new Confidant, which is very tooth-like. And in fact, the committee requested for all board members to receive a tooth so that we can practice with it and look at it and see how it feels. The main difference, and I like this testing organization, to be honest with you, I think they're very good. The main difference between them and the REB is the comprehensive treatment planning, where, again, they use the OSCE style versus REB, where the candidate has to come up with their treatment plan. We also, I believe Ms. Overfelt is present today. If she wants to talk a little bit about it, or if any of the board members have any questions about it, they could ask her. Is she available?
Dr. Sheila Overfelt.
Shayna Overfelt.
Yes, she is. We're getting her now.
Perfect.
Yeah, and if, appreciate it, Dr. Kirsch. And if we could keep her comments to about 5 minutes, that'd be great.
Okay, perfect. Thank you.
Hi, good morning.
Good morning.
How are you?
Good morning, Ms. Overfelt.
Good morning. Nice to see everyone. We gave extensive comments yesterday, and so I missed a little bit here between going from the live view to this. I'm happy to answer any questions. We appreciate the committee yesterday taking their time to hear both about our dental and our dental hygiene, both patient-based exams and mannequin-based exams. The one thing to communicate to the board is that we do currently administer the CDCA ADEX exam in Texas for dental hygiene. And this year for 2020, in these outstanding circumstances we have found ourselves in, we did administer the ADEX OSCE for dental hygiene to 101 Texas dental hygiene students. And then we also administered, the best that I can account for, about 328 Texas residents that actually practice outside of Texas that are hoping to come back home and practice within their state within their ADEX dental licensing exam. Dr. Kirsch, is there anything specific? Oh, Dr. Tillman, I'm sorry.
So on those 101 folks, what kind of data do we have, pass-fail, and is that similar to live patient or other means of typodont means of evaluation? Could you go into some detail?
Sure. So the OSCE component alone does not obviously test any hand skills component. So we are advocates of the two components being together. The way the Texas law was interpreted this year, because the OSCE is a clinical exam, occupational structured clinical exam, it did fall into your rules. There were also 3 other states that accepted just the OSCE alone, which was Oregon, Missouri, and Kansas, including, and then of course, Texas. So I understand with your changes that you are hoping to go with a psychomotor skills exam, and it being, as Dr. Kirsch said, live. So whatever that means is we can support it. The results on the mannequin-based exam were high this year. It was around 98 to 99% pass rate for, and this is dental hygiene, please. So, but please know that we are giving every candidate a patient that already qualifies. In a patient-based exam, the candidates are responsible to bring a patient that does qualify. So when we're giving them a patient that will qualify, that does reduce the pass-fail rates or variance. I will say for the student, we had 400 dental hygiene students take a patient-based exam. Even their statistics were higher this year. They were around a 94% pass rate. So they were doing well overall, better than average in post-pandemic for sure. For dental, and I'll really quickly cover this, what was enormous about our exam is, remember, we have administered the Confidant now to a full series of candidates. The pass rate between patient-based and mannequin-based was 94% in both anterior and posterior lesions. So what we were finding was the exact same reasons candidates were unsuccessful on the patient-based exam was the same reasons they were unsuccessful on the confidant-based exam. So to see those results be so in tune with each other makes us confident that the confidant is very relevant to a simulated restoration of an examination.
Thank you.
Yes.
Dr.
Thank you, Ms. Overfeld. And I know you guys have been working on Confidant way before COVID, back in 2017, right? And I do see some some really great benefits that you guys have been working on, because I know that our issue as a board with live patients is that we as dentists work on live patients, but I do see that most of the failures was from modifications, and that involves treatment planning. So are you seeing technical issues? Because I think that's our concern, is that you can't really truly simulate human teeth, but is that something that you could honestly say, hey, this is as close as we can get and it's good enough? But I do see, I like what you guys have done, because with the way you're doing it is that the candidate does not know what tooth. They have to diagnose modifications, and the caries are variable. It could be deep, it could be shallow, it could be, and I know you guys are testing on anterior class 3s and posterior class 2s, in general, but they don't know what tooth. And I like the fact that they have to diagnose on the spot and make their modifications. Yeah. Because with live patients, they have the benefit of screening their own patients. I mean, they're better prepared. They know what tooth. They pre-select good patients, family members or whoever. So I think that, you kind of we as a board have to weigh out, okay, what are the pros and cons? But I see your pros for me personally, outweighing the cons. But again, I appreciate you giving us some teeth to look at, because that's my hang up, is that, okay, is this close to human or not? Okay.
So a couple of things I want to address, which I heard you say, is this good enough? So for 3 years, it wasn't good enough. We pushed hard to make what was currently available on the market better. And that doesn't mean it stops now, right? We'll continue to try to make it better. How do we advance this product? So we don't want any board to accept something that's good enough, right? We're looking for the standardization of this process. And from my perspective, I work with the dental schools closely and dental hygiene programs. Their biggest takeaway when we start comparing, the pros and the cons, as you said, was that it's standardized to an extent, right? We don't have candidates bringing that minimal class 2 or class 3 lesion that once they prep the tooth, the decay is gone, right? They are having to take it a step further within this simulation because we can make that happen. So that in itself has been a big variable, hygiene-wise as well. The hygiene thinks from educators' standpoint, they feel it's a much more fair exam because candidates case selection is big in either scenario, right? And if the candidate chooses wrong in a case selection, one that's too difficult, that they're pushing themselves past a point that may not exemplify their best procedure that day. And I wish Dr. Champagne was here. Dr. Yu, I'm not a dentist, so I am speaking well above my range here, but I do have a lot of interaction here and appreciate the comments, but please know good enough is not where we're heading. We're heading to looking for something simulated. Many state boards are in this conversation now. They're asking us, we provide what the state boards want. If the state board wants a live patient, we will administer a live patient. But especially around the country, we've got more and more pushing for some type of simulated process.
Thank you, Ms. Overfeld.
Thank you.
Any other question, board members? Seeing none, moving forward with my committee report, we had three dentists. Oh, Dr. Yu.
We're just saying goodbye. Thank you.
Saying bye. Thank you.
Oh, okay. Sorry. I couldn't see her. Sorry. Moving forward with my report, we had three dentists come and ask for exception to board rule. The first was a widow of Dr. Lok Tan Bu, and that's 2021 QS DDS1. By board rule, Dr. Bu passed away in November of 2019. His name stays on the practice for a period of 1 year. They were looking for a 9-month extension. The board voted unanimously to give them a 6-month extension to be consistent with what we've done in the past. And if Ms. Studdard would like to add anything to that?
No. So the committee recommendation was to approve a 6-month extension.
So we have a committee recommendation to approve a 6-month extension. It comes from a committee. We don't need a second.
Right. We don't need a motion. Yeah.
Don't need a motion. Thank you. Any other discussion? Seeing none, Dr. Kirsch, could you give us a roll call for?
I will. Dr. David Tillman.
In favor.
Dr. George Kirsch, in favor. Ms. Lois Palermo.
In favor.
Dr. Brian Henderson.
In favor.
Dr. David Yu.
In favor.
Dr. Robert McNeil.
In favor.
Dr. Linda Burke.
In favor.
Ms. Lori Jones.
In favor.
Dr. Margot Melcher.
In favor.
Mr. Rodney Bustamante. And Mrs. Catherine Sisk.
In favor.
Dr. Tillman, the motion carries unanimously.
Very good. Thank you.
Out of committee.
One retrace, there was no committee recommendation as far as the CDCA. Is that correct?
That is correct. We are waiting on the governor to decide what we're going to do as far as live patients go in the state of Texas.
Okay. So continue 2021 Q2 DDS2.
Yes, this is Dr. Villalobos. He is a retired military dentist. He has been serving our country. He was kind of forced to retire 6 months prior to committing his 5 years by board rule. So he was 4.5 years into the practice. If he wasn't forced into retirement, he would have committed that. The board went ahead and waived the exception, gave the exception to board rule, and granted him by unanimous vote again. And Ms. Studdard, you can lead us in discussion of this if you wanted to.
Right. So he is requesting an exception to the licensure by credentials rule. He didn't meet the practice requirement. I believe he was only off by
6 months.
6 months. And so the committee voted to approve the request for exception to board rule.
Very good. So we have a committee recommendation for exception to rule. Any further discussion? Seeing none, Dr. Kirsch.
Dr. Tillman, Dr. Melcher here. Dr. Kirsch, could you just also provide explanation about that he was forced out to retire? It wasn't on a negative connotation. Wasn't it due to the military?
To the military age restriction. You're absolutely right, Dr. Margot. Thank you for clarifying that. It was due to his age. Exactly. Thank you.
Okay, roll call.
Dr. David Tillman.
Approved.
Dr. George Kirsch. Approved. Ms. Lois Palermo.
Approve.
Dr. Brian Henderson.
Approve.
Dr. David Yu.
Approve.
Dr. Robert McNeil.
Approve.
Dr. Linda Burke.
Approve.
Ms. Lori Jones.
Approve.
Dr. Margot Melcher.
Approve.
Mr. Rodney Bustamante. And Ms. Catherine Sisk. The motion carried unanimously. Oh, Ms. Catherine Sisk.
Approve.
Sorry, I jumped the gun.
That's fine.
The motion carries unanimously.
Every vote
Okay.
Thank
Our
you.
next DDS is a similar situation, but she had only practiced, as this is Dr. Foe, she had only practiced for 1.5 years before she went into residency. She did a pediatric residency, And under board rule, again, under a residency program, you do not qualify as practicing. So the committee did vote unanimously to not grant her exception to board rule. And I'll let Ms. Studdard lead us on this as well.
Yes, and just a minor edit, Dr. Kirsch. She was practicing 1 year, 8 months as a pediatric dentist after her residency. I believe you said 6 months. But yes, she was requesting an exception to our licensure by credential rule, and the committee recommended to deny that request.
Dr. Yu?
Okay, so, 101.3, I know it's vague on the definition of practice dentistry, because I know the rule is that you need to practice for a minimum of three of the 5 years. So, but also you could be a dental educator. So we're saying that if you're in residency.
In an accredited school.
Right.
Yes.
And she was, to my, yes. From what I read. So if you're in residency, that does not count for practice, even though there are a doctorate of, they have a doctorate of dental surgery, and she could have been in practice, but she decided to do a residency. So that's almost like a count against her to actually go into residency. Is that what we're interpreting the rule as?
I'll leave that to legal to respond.
So the rule or statute says has practiced dentistry for a minimum of 3 out of the 5 years immediately preceding the application. And so we're interpreting that to mean a non-resident type of practice.
Because in residency, they teach and they practice dentistry, right? And so for me, I did 4 years in residency, and I would have to, if I come from another state, I would have to retake the board again and basically be punished for doing a residency.
Dr. Rue, I wanted to also note, Dr. Rue, Ms. Studdard also noted at our meeting last week to Dr. I'm sorry, her name is
Dr. Foe,
that she could come to the state of Texas and work in a public health setting. That was sort of a stipulation from our rule. So she did give her some additional information and suggestions.
She would have to do that 3 years then.
Yes, nonprofit.
Yes.
Right. But I'm just wondering, whether if we need to bring this to dental practice committee and define what practice dentistry means for us, because I just can't see why a residency doesn't count as practicing dentistry.
Thank you. Ms. Kemp.
Yes. So to be clear, we need to look at our statutory authorization when we're talking about what is the practice of dentistry. If you all could take a look at Texas Occupations Code, section 251.004, subsection A2. A student of a reputable dental school who performs the student's operation without pay except for actual cost of materials in the presence of and under the direct personal supervision of a demonstrator or teacher who is a faculty member of a reputable dental school is exempt from the practice of dentistry. So that is not the practice of dentistry. So that's why that rule comes into play. Now, obviously, I'm not a dentist. I've never been through a residency program. So if you all had questions, about what that residency actually entailed, if it fit into that specific definition based on what Dr. Yu just said, as far as a teaching component or some other component there, that maybe there's something outside of that rule, such as without pay or something of that sort. If they are paid, maybe that's a different question or a different issue. But that's the rule you need to look at when you're talking about any sort of dentist that's a student or in a residency program as a student to get a specialty when we're considering what their practice of dentistry is.
Very good. So I have Ms. Jones, then I have Dr. McNeil, then I have Ms. Palermo, then I have Dr. Henderson. Ms. Jones.
Thank you. Just to kind of follow up with what Dr. Yu was saying, no, she did practice for 4 years prior to going to residency. Is that correct?
Yes, 2010 to 2014.
Okay, and then she did the 2 residencies, the AEGD and the pediatric.
Pediatric, that's right.
Okay. That's just what I just wanted clarification on. I'm kind of in agreement with Dr. Yu. I feel like that we're punishing this individual for furthering their education. And, you know, I'm not sure about all residency programs. Maybe there is some that are paid in light of what Ms. Camp was talking about with the statute. So I don't know if there is a way that we can evaluate it and look at that, because they do continue working. And, you know, what if she still worked one day on the weekend for the past several years? Would that have made it different right now?
Very good. Thank you. Dr. McNeil.
Great. I would speak in favor of giving an exception to this individual. Many of my comments mirror what was just said by Dr. Yu and Ms. Jones. You know, we're having someone who is a dental specialist, requiring them to take a general dental licensing examination and then practice as a dental specialist. Residency is very involved. A lot of these people do get stipends. I was paid throughout most of my residency, and so that can certainly give some leeway there. I would also hope that licensing would kind of look at this issue, the licensing committee in general, because I know we have this happen a fair number of times, whether it's military people, whether it's people like this. You know, she practiced 4 years, did a general practice residency year, did residency training. You know, we had the OMS that was the faculty member at that prior meeting. You know, it's ridiculous that we're put in a box like we are. So, and to protect the public, you know, I see nothing here that this person is nothing but could be a help to the public.
The unfortunate, I know somebody else is speaking, but can I speak to that real quick? The unfortunate circumstances, we have to follow our statutes and we have to follow our rules. If we go and grant this, it's going to open Pandora's box to anyone who wants to come to the state and practice. That's just my opinion. I'm sorry that I jumped in front of somebody. Go ahead, whoever's next.
Ms. Palermo.
Yes, I was just going to say what Lori had said was the fact that she had practiced for 4 years before she did those 2 residency programs. And I agree with Dr. Yu. I think maybe the dental practice committee needs to take a look at that.
Very good. Dr. Henderson.
Thank you. And I you know, I'm kind of torn with this whole case as well. We have these rules and we have our general counsel that guides us in trying to determine what is right and what is wrong, to follow the rules, because I'm not a believer that we should have the power to change what the citizens of Texas have elected their leaders to write these statutory laws that our attorneys interpret. I would like to also comment on Dr. McNeil. I totally agree. If you're doing a residency, you have a license. She had a current license, and just because she was doing a residency doesn't mean she's not practicing dentistry. And whether she got paid or not, she could walk out the door on Saturday and Sunday and clean someone's teeth or provide dental care. She had the ability to practice. So in theory, I think she probably was practicing, but I'm not an attorney, and I would like to encourage the general counsel to maybe meet again with the licensing committee and amongst themselves, maybe even the attorney general, to get this clarified so we don't continue to punish dentists that probably could qualify in these circumstances. And that's all I'm going to say. I'm going to probably vote against it because I'm going to go with the licensing committee, but I don't really want to. Thank you.
I will add one more thing. She is moving here to be with her mom, who is having some medical compromises. So,
Dr. Yu.
Is there a way to determine legislative intent on the Dental Practice Act that was quoted? I mean, I just, I agree that we should never go against statute, and but I really do see that she is a dentist, and residency should not trump that. I mean, she could legally practice, and she did pass her boards, I assume, to be able to practice. But we're just, I just don't want to go against statute either on this.
Any further discussion? Seeing none, Dr. Kirsch, we have a motion before the board of a committee recommendation to deny exception to board rule in the case of 2021 Q2 DDS3. Could I have a roll call, please?
Dr. David Tillman.
In favor?
Dr. George Kirch, in favor. Ms. Lois Palermo.
In favor.
Dr. Brian Henderson.
In favor.
Dr. David Yu.
I would abstain.
Dr. Robert McNeil.
Against.
We lost Dr. Kirsch. Ms. Palermo, have you voted?
Yes.
Ms. Palermo?
Yes, I voted in favor.
Thank you. Who else has not voted? Ms. Sisk?
I think I was next. I'm in favor. Dr.
Okay.
Berg.
And Dr. Meltzer?
In favor.
And Ms. Sisk?
In favor.
In favor. The motion.
Ms. Jones.
Ms. Jones.
Against.
Dr. Kirsch, are you back with us? So the motion to approve the committee's recommendation to deny the exception 2021 Q2 DDS3 has been approved by the board. So Ms. Studdard, we've had many comments as it relates to the practice of dentistry. Should we look into that and then maybe bring it up at the next dental practice meeting? Would that be acceptable?
I'm back. Sorry, guys.
I completed the roll call. The motion passed, and talked with Ms. Studdard. We're going to look at dental practice this item, so that will be coming up at our next dental practice meeting, or they at least staff will research this.
Great. Thank you, Dr. Tillman.
Yeah, no worries. Committee recommendation, possible action. Dr. Madhu Shrestha.
Yes, that's right. And I'll turn this over to Ms. Studdard to give us clarification on the REB.
I'm actually going to defer to our licensing director, Ms. Christine Mendez, if that's
okay. Thank you.
Ms. Mendez.
Good morning. Yes, sir. Sorry about that. Good morning, board members. We have a request from Dr. Sharitha Madhu requesting to take the regional clinical exam. Dr. Sharitha is currently in a residency program. I was requesting to take the REB now along with all the other dental students. And just to give you a little bit of what our current processes here in the agency are, we currently approve and will grant approval for students who complete the board-approved coded accredited specialty program to take the regional exam. If the student is within 6 months of completing this program, has successfully completed part 1 and part 2 of the NBDBE, and is able to provide proof of completion of a dental school. Of course, if it's in a foreign language, it has to be translated in English.
It looks like Dr. Shrestha is available for any questions.
Yeah, I'm here.
And this was voted unanimously to grant exception to board rule. So
actually, the committee did not.
Actually, it was 5-1. I apologize. It was 5-1. We had someone abstain. Yes.
No, Ms. Studdard.
The committee, Dr. Kirch, actually denied the request.
Recommended denial unanimously.
Oh, I'm sorry. That's what it was.
Something more to say?
Yes. Ms. Shrestha, Dr. Shrestha is with us. Welcome. Could you spend maybe 5 minutes, less than 5 minutes on reviewing with the board? We appreciate you coming.
Yeah, thank you everyone for having me here. I'm a second-year ORPATH resident, and I'm currently also a graduate student representative to Texas A&M Health Science Student Governing Board. Actually, the problem with international resident is when we apply for our board exam, like the REB exam, the Texas State Dental Board has to give the confirmation for the resident. However, the rule for getting a confirmation is that we are only able to do that 6 months prior to residency. So because of this process, 6 months means like we can only give the exam in December, but the registration for the REB exam actually starts within September. So because of that, none of the international residents before me were able to give the exam from the Texas state. Unfortunately, they had to fly over to the other adjoining states, like various states around Texas, to give their REB exam. So this 6-month rule, I definitely understand the rule, but then because of this 6-month prior to completion, none of the residents were able to give their board exams from the school that they are graduating from. So all of the residents had to fly to other states. And this is a very difficult process for the resident, because as we are trained here in Texas, like for example, Texas A&M, I know the patients here, I see patients here, and I have full access to all the lab facilities working here, getting trained here. However, when it is the time for my actual exam, I have to fly to some other state. And I think it's also a loss of resources for the state of Texas. So I would kindly request the Texas State Board to look into this matter that all the international students are currently facing. I have been personally in touch with all the international students who have graduated from Texas A&M, but unfortunately, none of them have been able to give their exam from the university itself. And it's a very sad thing for us, because we will have to resort to some patient managing services in other state. And it is also troublesome for us, because the patients that we know, whom we know, and then the environment that we are working in is not available to us at the time. So I would really like to request the problems that the current international students are facing, and then see what could be done in order to, help us with this problem. Thank you very much.
Thank you. Do we have any questions?
Dr. Henderson.
So I have a question. I'm a little struggling with the time frame. 6 months before you graduate, you can take the REB?
Yeah, that's the current rule. And 6 months before, we usually have our graduation in June. So 6 months before that is around December. But the REB rule says that we have to register, especially the Texas REB. Most of the colleges have the registration within September. So we have the first exam, CTP, which we have to appear within November. So if the 6 months rule is there, then no one can appear for the CTP exam. That is the first part of the REB, which is usually given in November, within November. And the registration has to be done within September. So it's like almost 9 and 10 months before our residency is over. We have to start for the registration program.
And I was just running it, and I don't know this answer. Are you telling me you can't take the CTP after you've taken the clinical part of REB?
No, the CTP has to be taken before the clinical part of REB. CTP is usually around November. REB is usually around in April in Texas. So the REB exam itself is in April, but the CTP exam, which is the first part of REB, has to be taken within November. And to write the CTP itself, we need to have the registration done. And the Texas state only allows us to have the registration like during the last 6 months of our residency. So unfortunately, none of the international students could apply or could write their clinical exam or could take their clinical exam in the current institution that they have been graduating from. So I think it's a very, unfortunate thing.
Okay.
So back to my question, I don't really know this. I know Mark Christensen is on this call and probably clarify, but I'm going to again ask you, can you not take the CTP after the clinical exam?
No.
It is not a requirement to take the CTP prior, is it?
As per my knowledge, it is prior to the REB clinical exam.
No, I know normally people take it. I'm asking you, can you not take the CTP after the clinical exam? And then you could take the REB at your institution where you are.
But CTP exams are usually in November, right? So.
Well, that's correct.
So as for my knowledge, we cannot take the CTP after the REB. We have to take it before the REB, the clinical exam of REB.
Okay. Thank you.
Okay,
Ms. Palermo.
Yes, I don't think you're beholden to have to take REB. We accept all the regional exams. So have you looked at CETA and credits and?
But the institution that we are currently in only does the REB exam from our institution. Like if you want to do the board exams from our institution, so our institution only provides the REB exam. It doesn't provide the other exams here. Of course,
but you could go somewhere else and take credits or CETA or
the problem right now.
Like, yeah,
just
like the other students.
Yeah, that's
hygiene students do.
Mm-hmm. Because we'll have to that way we'll have to look for like patient management services and and go to some other place and then be familiarized with their setup and I think that's a big disadvantage to the international students right now.
So all of our dental hygiene students are at a disadvantage then because they can go out of state and do it and have to find a patient and fly them there?
I do not know about the dental hygiene, but if they
that's how they do it. So you wouldn't be at any more of a disadvantage than any of them. But also too, I mean, you've done 2 years of residency, right? And you can actually, aren't you supposed to be doing this after your 3rd year of residency? Or am I mistaken?
So once we graduate from our university, we cannot schedule our patient or our appointments here from the university itself. Like until we are a student here, we will be allowed to use the lab and everything. But once we graduate out of the university, it is not possible to do that. Yeah, and the main thing is we want to be able to do the exam here in Texas if possible, so that's the only concern.
Sure.
Dr. Henderson?
Miss Jones first, actually.
Sorry.
It's all right. Miss Jones.
Thank you. I was actually, can I just, from legal or from Miss Menendez, if I can get the rule number that shows the 6-month requirement?
It's not specified in rule, the 6-month requirement, but the rule that we are referring to is 104.
101.2.
101.2. Thank you.
B4.
Thank you. Anything else, Ms. Jones? Dr. Henderson.
So I just wanted to clarify a little bit. I'm a faculty member at Texas A&M where you're in school. And I know that if a student comes and registers for the REB and they're no longer a student, they do have access to the lab, et cetera, during the REB exam. So I just thought I'd clarify that for you.
Okay, that would be good then. Thank you.
Anybody else? Dr. McNeil. And then, I'm sorry, Dr. Yu was ahead of Dr. McNeil. Dr. Yu.
Dr. Sharitha, there are a lot of examinations, and I realize this is a huge inconvenience, but there are a lot of examinations, even in REBs, that are SIM. So, you don't have to worry about, patients traveling or hiring a service. So, no matter what happens here, I mean, I would look into that also as a alternative.
Very good. Dr. McNeil.
I'm going to vote in favor, if it's surprising, of giving an exemption here. I think from an intent standpoint, we want people to do this in their last part of their residency training. I think it's quite onerous, and I can appreciate the challenges, Doctor, that you've sort of talked about. You're an oral path resident. Is that a correct statement?
I'm an oral path resident.
So you haven't been doing restorative dentistry, I would assume. It's certainly a difficult sort of, we're already asking you to do a general dental clinical examination in order to practice oral pathology. I get it. That's how it's set up. But it's so onerous to make someone in a situation like you to go out of the state and do all these things. Once again, the intent is towards the end of residency. We arbitrarily said that's 6 months. And that's dependent on scheduling of an availability of a REB examination. So you're getting caught in scheduling snafus, is my opinion. And why are we doing more?
Yeah, scheduling, because right at the time of scheduling, we need some kind of verification. And I think it's only according to the rule in Texas, it's only the Texas State Board that can verify us. Like, our program director or dean would not be able to verify us according to the current rules. So that makes it a challenge. REB doesn't have any problem. We can even appear for the REB before our NBD Part 2. That's what I learned from the REB website. But the only problem here is our verification, because REB needs someone to verify for our status. And unfortunately, at this point, only the Texas state can verify for an international resident. Not even my current dean or my program director here is able to verify for my position. So that's the only thing I would want to highlight. And at my position, I want to practice oral pathology, but there's also a thing that I need to have a general license to practice oral pathology once I'm a board certified oral pathologist. So I know that the rules have been made and all, but I was just wanting to request if there is something, that could help people like me. I know people have already had the option before me. They said, they didn't want to say anything because they just thought they would go for the other option, but they said it was not an easy one for them. That's the only thing I want to highlight, the problems faced by an international dentist to the board, because I feel like they are here to support us. So that's only my request here.
Yes, thank you.
Thank you very much.
Again, this came out of committee for denial 5-1.
Right. Ms. Jones.
I just get some further clarification on where the 6 months came from, because reading through that rule, I don't see the 6 months.
So I can speak on that. That's okay with you, Lauren. Mm-hmm. So in 2017, so prior to 2017, international students actually had to wait until they completed their specialty before they could request approval from the board to take a regional exam. After 2017, we made an internal process change to grant the approval 6 months before they graduated.
Thank you. So, Dr. Kearse, we have a recommendation from licensing to approve the committee's recommendation. Could we have a roll call? Seeing no further discussion. Yes, Ms. Mendez.
Lauren, I think that the recommendation was to deny the request.
That's correct. Thank you for the presentation.
Dr. David Tillman.
Approve.
Dr. Kearse, in favor. Ms. Lois Palermo.
So if I vote in favor, that means no, right?
Yes.
Yes.
Okay, then no.
Against?
So you're voting in favor of the committee?
Yes.
Okay.
Yes, I'm voting in favor of the committee's recommendation.
Thank you.
Okay. Dr. Brian Henderson.
For.
Dr. David Yu.
Against.
Dr. Robert McNeil.
Against.
Dr. Linda Burke.
In favor.
Ms. Lori Jones.
Against.
Dr. Margot Melcher.
Abstain.
Mr. Rodney Bustamante and Mrs. Catherine Sisk.
In favor.
So the motion carries 1, 2, 3, 4, 5, 6 to 3 and 1 abstain.
Thank you. In favor of the committee's recommendation to deny the exception to the rule.
Exactly.
So it seems, Ms. Studdard, like we have a similar issue with, could we kind of bundle these and let dental practice look at both of these or research this? That would be a good step forward. And we appreciate your time, Doctor, and all the best. Dr. McNeil.
And Dr. Tillman, just to your point that you just discussed, I'm fully in favor of that. And I know a lot of my fellow colleagues don't like to be in the position that we're in. And I always am reminded with what we received in government training with the governor's office is just why are we doing what we're doing? And if we can get some clarity and things that make sense as we move throughout this process, I think we're all on the same page here, and we don't want to make things overly onerous as we protect people.
Yes, thank you.
Totally agree, Dr. McNeil.
Dr. Kears, if we could, I have about 10:32. I'd ask for a recess. Let's do a 15-minute recess.
Okay.
Stretch our legs, and then we'll continue with your licensing committee.
Perfect. Thank you, Dr. Tillman.
I'll call us in recess. I have 10:33, and we'll come back. If we could turn off the audio, that would be great. Thank you.
Thank you.
Recorders. Is this going? Hello?
Yes.
Sorry. Thank you. Action. Very good. Okay. I'll go ahead and call us back into session. Convene. I have 10:50 a.m. Apologies for the interruption, Dr. Kirsch.
No worries. All right. Next, the committee.
Could I call on Ms. Stutter? We have a previous individual that was supposed to come before us. So, Ms. Stutter.
Dr. Foes would like to speak. She was regarding agenda item DDS2 on the agenda regarding a request for exception to board rule. Just to let Dr. Foes know, the board has already has voted to accept the committee's recommendation to deny, but we are giving her an opportunity to speak because she would like to address the full board. And Dr. Foes, you have the floor.
Is she with us?
Okay, can everybody hear me?
Yes. Yes.
Okay. Hi, good morning, everyone. Thank you for letting me talk to you. I realize you did already vote. I was watching the meeting live. And I know there's probably not much at this point that I can do, but I just kind of wanted to, the reason for wanting to come down here, and as I kind of stated yesterday at the license committee meeting, the reason to come to Texas is to be close to my mom, who's been going through some recent health struggles, and there's more stuff going on. She's going through testing right now with her. She has IBS, and she's had a lot of symptoms lately, and she may have to have surgery regarding that. They're trying to figure out what's going on. So, I want to be here for her for that, and then also, I didn't disclose this yesterday, but selfishly, I'd like to be down around my family. My mom and my sister also lives down here because I've recently gone through a separation from my husband, and just to have a support system around for myself. I don't have any family back in Illinois anymore. So going back there, I wouldn't have any, much of a support system around, but it's just, I have practiced dentistry ever since, I graduated dental school in 2011, up until March of 2020 when COVID shut everything down. I realized 3 of those years were in residency, but I was still seeing patients 5 days a week, 8 hours a day. I was still seeing and treating patients during my residency. And it just almost seems like, in a way, indirectly, I'm getting penalized for going back and furthering my education and, pursuing what I want to do, being a pediatric dentistry, which I don't regret for a second. I love what I do, but if I wouldn't have done that and just stayed practicing through all those years, then it wouldn't be an issue to get a license through credentials. But because I decided to go back and do residency, I don't qualify. So I don't know. I know Ms. Mendez yesterday said something about maybe applying for a temporary license, working in a nonprofit organization. And I briefly read the bylaws on that, and I thought it said that the same stipulations as license for credentials applies to that, which would mean I'd still have to have 3 years of practice. Maybe I didn't read it closely enough, but I just wondered if any of you have any other recommendations on, what I can do in order to be able to come down here and practice dentistry.
So any questions from the board to Ms. Dr. Henderson?
Well, I'm going to leave the licensing expertise to the licensing committee and Ms. Mendez, but I would just give this doctor a little encouragement. I think she's going to be great, and we'd love to have you. And I'll tell you, you can become a faculty member in a paid position immediately, and I'm pretty sure a lot of the schools need pediatric dentists on staff if you qualify for that. But that's just something that I would throw out to you.
Okay, thank you so much.
Dr. Burke.
Hi, Dr. Foes. This is Dr. Burke. I had a question for you. And first, I wanted to let you know this was a tough one for all of us because we know you're an excellent clinician, and it's just the way our rule is written that kind of keeps our hands tied. So please understand that. But did you have a stipend position in your residency, or were you a non-stipend position?
I had a stipend position.
Okay. That was my question. Thank you.
Did you moonlight? This is Dr. Kirch, Dr. Foe, and again, this was a very difficult decision for all of us to make. Were you working outside of your residency? Were you seeing patients on your own in a private setting away from the residency program, like on the weekends?
I would have liked to, but the guidelines for our specific residency program, because we got the stipend, we were not allowed to moonlight.
Okay. All right. Thank you. Thank you.
Then Dr. McNeil, Dr. Henderson. Oh, you're good? Okay.
Dr. Kirsch asked a question that I wanted to confirm. Most programs prohibit that, but some don't, and he asked the question. Thank you.
Okay. Okay.
Dr. McNeil.
In response to the newly provided information regarding Dr. Foe's receiving a stipend, I believe that will allow us to follow statute, and I move to reconsider giving exception to board rules for candidate Q2 DDS3.
And I second.
Motion on the floor to reconsider. And Dr. Burke, was that a reconsider second? Okay. Thank you. We have a second by Dr. Burke. Legal interpretation.
Point of information.
Okay.
Sure. Point of information. If in fact, in light of acknowledging a stipend, if legal says that that's proved, the board doesn't need to do that because it will be within the purview. And I think it's reaching for us to make that exception because she would automatically qualify. So I would defer this back to legal and to the licensing department.
Okay, a couple of things to consider.
Do you have any?
I would say that the exception should still be denied for exactly that reason. If
you can address it.
Yeah. I actually concur with Dr. Henderson. It's something that we should certainly, as a legal staff, look into outside of this meeting and not make a hurried decision on, because it will have certainly some lasting effects on people who do want to come to the state and practice after continuing their educations and residency. But I do concur with Dr. Henderson. If we do determine that it was a stipend position and that does qualify, she would meet the rule for licensure by credential, and then she wouldn't need the exception to begin with. So I do still feel that your vote on denying the exception is okay, and based on what we determine outside of this meeting, once we're able to look into that, determine if that's in the spirit of the statute, if we determine it is, she can have a license by rentals.
So y'all, Casey, what I'm hearing is y'all are going to look into that.
Yes.
And y'all are going to go, and if she does fall within that, even though we voted it down, y'all could go ahead and grant her a license. Is that correct?
Correct.
Okay.
She would then qualify.
Great. Thank you.
Well, I would recommend if we go back to look at this, then it would have to come back to the board again at the next board meeting. Does that sound correct, Christine, for approval?
No, if internally it's determined that her residency and she's working and she's able to provide the clinical proof of practice, then it doesn't need to come back to the board, because then we'll have the documentation needed to continue the process of the application.
Okay.
Perfect.
So currently we have a motion on the floor to reconsider outside what legal is going to do.
Dr. Tillman, I don't think we need that motion, to be honest with you, because
you withdraw.
Thank you. Right, because legal's going to look into it. If she qualifies, she's going to qualify regardless of how we voted. Dr. Henderson?
Dr. McNeil, you had a motion on the floor to reconsider.
Did David, you just try to withdraw my motion? Is that what just happened?
Oh, no. We need to withdraw the original motion to accept the committee's
I think we're all in the spirit of what's the right thing to do here. I think we all had challenges with that prior vote for various reasons. We're trying to do the right thing here. And if legal doesn't have a problem with having something on the books that was just passed denying exception and saying that they will take a look at this new information, provide evidence of a stipend, be okay with that, and not have to have that come back to another board meeting for approval and delay this dentist's license, then I'm okay withdrawing my motion on that.
Yeah.
So I'm going to withdraw your motion to reconsider. Thank you. Ms. Jones.
Just wanted clarification. Will she need to reapply since we have denied at this point?
Legal?
No.
Ms. Studdard?
Kristen.
Or Ms. Kemp?
Ms. Mendez, please.
Ms. Mendez. Hello.
We'll get it right. No, she won't have to reapply. We still have the application and her fee. We'll just require the additional documentation.
Perfect.
Ms. Mendez, can we immediately, after our board meeting, start looking into this and verify her stipend so we don't delay time on this?
I mean, if she wants to, she can go ahead. The ability to download the clinical affidavits available on the website. She can start getting that process going on her end while legal internally is coming up with a decision. So
perfect.
Okay. All right.
Dr. Foe, are you still on the line?
I am. Yes. I'll definitely do that then. Thank you so much, everyone. I really appreciate your reconsideration.
Very good. Thank you, Dr. Foes. Dr. Yu.
Point of order. Do we need to withdraw the original motion, which is to accept the committee's recommendation for denial?
That would be not out of order. Staff is gonna look into it. Their recommendation would make the motion moot. Exactly. And at that point, the motion would be taken off, but not until then.
I agree.
Okay. Thank you. And Dr. Foes, we'll look into it and we appreciate your coming on the line. Dr. Kears.
Thank you so much.
Yes, take care. Committee, licensing committee report and recommendation related to Texas State Technical College's request for approval for nitrous oxide monitoring.
Right. So Ms. Rico, I believe, was supposed to be in our meeting yesterday. She was not. So we did not vote on this. They were on our website as a provider, and in 1999, and I guess someone looked on, or someone took a course. They tried to get approval for that course in nitrous, and it was denied. And it's because it wasn't on our website as an institution of approval. So they were supposed to be at our meeting yesterday. No one showed up. Hopefully Ms. Rico is here today to give light on that, and we can vote on it today as a board if that's appropriate. I'll defer to Ms. Studdard on this as well.
Ms. Rico actually isn't here today either.
Okay.
So this is an agenda item. There isn't a committee recommendation, but it's an agenda item. Should we still address it as a board?
I think that's fine.
Okay. So do I have a motion to approve or deny the Texas State Technical College's request for nitrous oxide monitoring course? Dr. Henderson.
I'll make a motion to approve the course and the outline as proposed and on our webpage.
Okay.
I'll second.
So we have a motion to approve by Dr. Henderson. I just lost video. And Dr. Yu seconds. Discussion. What? Ms. Jones.
I just wanted clarification. So they've been doing courses since 1999 for the nitrous, and we've been accepting all those students that have gone through their program. Is that correct?
That is correct.
Dr. Henderson.
So I'm a little unsure of how they were approved course and how they became unapproved, but I'm going to guess because the CE a few years ago, they were talking about if you weren't a provider and you weren't continuing a provider, they were going to remove you. I don't know if that's what happened. I don't know what happened and how they fell off, or if they changed their name. I don't know that. And I don't know if staff knows that history.
Ms. Mendez, history.
She didn't.
Unfortunately, I do not know the history. When staff rejected the application, the applicant reached back out, and we were going back and forth about it was approved. So in conversation with Ms. Rico, it was like, hey, can you provide me the documentation that the agency sent you when your course was reviewed? And so it was the same issue with them with turnover. So they were unable to locate the document. I will also add is that what we're seeing on our end is COTA accredited schools automatically assume that because they offer this program that their nitrous course is approved. And our rules have that fine print that says that the course it has to be COTA approved and board approved.
Thank you.
Thank you. Ms. Jones.
My next question to follow up with that is that will this be retroactive? So will all the students that have been denied recently, will they be accepted, or is this going to be from today on this program is approved?
I don't see a problem in accepting retroactively. Because I know our rules say it's good for 5 years, but I don't see a problem with it unless Lauren, you see something like that.
Yeah. Dr. Henderson.
Are we aware of any applicants that have been denied because they weren't in this program?
I only know of one.
Yeah. Thank you.
Question. They've completed their application process. Everything is in order for them to be approved as a provider. Is that correct, Ms. Mendez?
Yes, sir.
Okay. Any further discussion? So we have a motion on the floor made by Dr. Henderson to approve Texas State Technical College request for providing nitrous oxide. I forget who seconded it. Did we have a second?
Dr. Yu.
And Dr. Yu. Any further discussion? Seeing none, Dr. Kirsch, could we have a roll call, please?
Yes, sir. Dr. David Tillman.
In favor?
Dr. George Kirch, in favor. Ms. Lois Palermo.
In favor.
Dr. Brian Henderson.
For.
Dr. David Yu.
In favor.
Dr. Robert McNeil.
In favor.
Dr. Linda Burke.
In favor.
Ms. Lori Jones.
In favor.
Dr. Margot Melcher.
In favor.
Mr. Rodney Bustamante. Mrs. Catherine Sisk.
In favor.
The motion carries unanimously, Dr. Tillman.
Thank you.
Okay.
Next request for approval.
Yes. Next, we have possible action for Dallas College. So request for an RDA course as a provider. And Dr. Vandenbush did talk to us, and I don't know if she's here today, but this was voted unanimously at a commission to approve. College.
Dr. Kirch.
For an RDA course as a provider, and Dr. Vandenbush did talk to us, and I don't know if she's here today, but this was voted unanimously at a commission to approve. Committee.
Very good. So we have a recommendation by committee, licensing committee, to approve Dallas College's request for approval to become a registered dental assistant course provider. Is a committee recommendation, doesn't need a second. Any further discussion?
Makes me feel like a damnation.
Dr. Tillman?
Yes, Dr. Melcher.
I just wanted to let my fellow board members know that in their test that they would distribute to their students, there were some questions regarding the TSBDE. So I did ask that they consult with our executive director before they post any such questions, just to make sure that they are correct.
Very good.
Thank you, Dr. Margot. That's correct.
This is Dr. Vandenbush. I did submit those questions last night.
Very good. Any further questions for Dr. Vandenbush? Seeing none, we have a motion by our licensing committee to approve Dallas College's request for approval of registered RDA course provider. Comes from our committee, doesn't need a second. Seeing no further comments, Dr. Kearse, could we have a roll call, please?
Dr. David Tillman.
In favor.
Dr. George Kirch in favor. Ms. Palermo?
I did have one question. So this is just for a CE provider for dental assisting and not hygienist and dentist as well. It's just for assistants.
That's correct.
Okay. And I'm for.
Palermo was for. Is that what I heard?
Yes.
Okay. Dr. Henderson?
For.
Dr. David Yu?
For.
Dr. McNeil?
For.
Dr. Burke?
For.
Ms. Jones?
For.
Dr. Melcher?
For.
Mr. Bustamante? And Ms. Sisk?
For.
Dr. Tillman, the motion carries unanimously.
Thank you, board. Dr. Kearse, committee recommendation and possible action 22 Texas Administrative Code 108.54 advertising specialist. Could you?
I will turn this over to Ms. Studdard, and we'll take each one of these independently.
Perfect. Thank you.
All right. Rule 108.54 is concerning the advertisement of recognized dental specialties. This amendment will update the language to include recently recognized dental specialties as approved and adopted by the ADA's National Commission on Recognition of Dental Specialties and Certifying Boards. The three specialties include oral medicine, dental anesthesiology, and oral-facial pain. And the amendment also updates the language to show that the specialties are approved by ADA's National Commission on Recognition of Dental Specialties and Certifying Boards.
Very good. Any discussion? Seeing none, Dr. Kearse, could I have a roll call?
Yes, sir. And again, this is for advertising specialties only, right?
Correct.
Okay. Dr. David Tillman.
In favor.
Dr. George Kirch in favor. Ms. Lois Palermo.
In favor.
Dr. Brian Henderson.
For.
Dr. David Yu.
In favor.
Dr. Robert McNeil.
In favor.
Dr. Linda Burke.
In favor.
Miss Lori Jones.
In favor.
Dr. Margot Melcher.
For.
Mr. Rodney Bustamante. And Mrs. Catherine Sisk.
In favor.
It carries unanimously.
Thank you, board. Committee recommendation, possible action on 22 Administrative Code 119.1 oral medicine. Dr. Kearse.
Dr. David Tillman.
So we have a motion on the floor. Any further discussion? I didn't ask for that. I'm sorry.
Oh, I thought you were asking me to do roll call.
Any discussion? I just want to make sure. Any questions? Okay.
The committee recommendation.
I have a discussion, Doctor.
Yes.
I just wanted to make sure this is coming out of committee for a recommendation for Dr. Kearse's committee on what you just said.
Right. So we have a committee recommendation to accept 22 Texas Administrative Code 119.1 oral medicine. It's a committee recommendation. Doesn't need a second. I just wanted to make sure we had a discussion answered. Seeing none now, Dr. Kearse, I apologize. Roll call.
All right. Dr. David Tillman.
In favor.
Dr. George Kirch in favor. Miss Lois Palermo.
In favor.
Dr. Brian Henderson.
For.
Dr. David Yu.
In favor.
Dr. Robert McNeil.
For.
Dr. Linda Burke.
In favor.
Miss Lori Jones.
In favor.
Dr. Margot Melcher.
For.
Mr. Rodney Bustamante. And Mrs. Catherine Sisk.
In favor.
All right, that motion carries unanimously.
Very good. One more. Dental anesthesiology.
We have two more. We have two more.
Thank you.
Yep.
Possible action related to 22 Texas Administrative Code 119.11, dental anesthesiology. We have a motion from committee. Doesn't need a second. Do you have any discussion related to this motion? Seeing none, roll call, Dr. Kirsch.
Dr. David Tillman.
In favor.
Dr. George Kirch, in favor. Miss Lois Palermo.
In favor.
Dr. Brian Henderson.
For.
Dr. David Yu.
In favor.
Dr. Robert McNeil.
For.
Dr. Linda Burke.
In favor.
Miss Lori Jones.
In favor.
Dr. Margot Melcher.
In favor.
Mr. Rodney Bustamante. And Miss Catherine Sisk.
In favor.
Again, it carries unanimously.
Very good. Committee recommendation, possible action, 22 Texas Administrative Code 119.12, oral facial pain. We have a motion from the committee. Doesn't need a second to approve. Any discussion by the board? Seeing none, Dr. Kirsch.
Dr. David Tillman.
In favor.
Dr. George Kirch, in favor. Miss Lois Palermo.
In favor.
Dr. Brian Henderson.
For.
Dr. David Yu.
In favor.
Dr. Robert McNeil.
For.
Dr. Linda Burke.
For.
Miss Lori Jones.
In favor.
Dr. Margot Melcher.
In favor.
Mr. Rodney Bustamante. And Mrs. Catherine Sisk.
In favor.
And that motion carries unanimously. Dr. Tillman, that's the end of my licensing committee report.
Thank you, committee, and thank you, Dr. Kirsch. We appreciate your work and dental practice. Dr. Yu, could you lead our discussion on committee report and recommendation?
I'd like to thank my committee, Ms. Jones, Dr. Henderson, Mr. Bustamante, who joined us, and Dr. Tillman. We had a good discussion about 3 topics. The first action that we proposed was the motion to amend 108.8 to include cone beam CTs as a reasonable cost of $30. And if I can have Ms. Studdard explain what came about and why this was brought up.
Yes, Ms. Studdard.
We had a correspondence received from Texas licensed dentist, Dr. Ford. He was requesting clarification on how much dentists should charge patients for a copy of a CBCT scan and proposed that the board specify a fee in board rule. He proposed that the fee should be $80 at a minimum. Committee did have a discussion on that and determined that the charge should be $30. And so maximum. And so there's going to be a 108.8 G3F to include that language.
108.G3F.
It's going to be in addition to the 108.8 rule.
Gotcha.
To specify that the charge shall not exceed $30 for a duplication of a CBCT scan.
Very good. Now, did Dr. Ford join us, or is he?
No, he did reach out to TDA. Diane Rhodes is available if any board members have any questions.
Very good. So we do have a committee recommendation, 108.G3F, to accept a maximum charge of $30 for the as a reasonable fee for dentists to charge patients for copies of CBCT scans. That's a committee recommendation. We don't need a second. Any further discussion? Seeing none. Dr. Kirsch, could we have a roll call? Excuse me. Yes, Dr. Kirsch, a roll call.
Yes, sir. Dr. David Tillman.
In favor.
Dr. George Kirch, in favor. Miss Lois Palermo.
In favor.
Dr. Brian Henderson.
For.
Dr. David Yu.
In favor.
Dr. Robert McNeil.
In favor.
Dr. Linda Burke.
In favor.
In favor.
Dr. Margot Melcher.
In favor.
Mr. Rodney Bustamante. And Mrs. Catherine Sisk.
In favor.
Dr. Tillman, the motion carries unanimously.
Thank you, Board. Dr. Yu.
Thanks, Dr. Tillman. Our next agenda item was something that I wanted to include in my dental practice committee, just as a discussion and possible committee action concerning 108.7. And this involves informed consent. And a lot of what we're seeing from our ISCs are respondents that are putting a blanket informed consent on all their treatment plans and not necessarily for each procedure. And I think coming out of committee, we decided that we're going to have board attorneys explore clarifying the language for informed consent and looking at any unintended consequences with it. So there was no action from our committee on this matter at this time.
Very good. Ms. Stutter, do you have anything else?
No.
So the language states that it's by procedure. So that would be implicit in suggesting that each case, each procedure have a individual consent related to potential ramifications, consequences that might affect the patient's acceptance or refusal. Is that accurate, Dr. Yu?
Yes, and just to clarify 108.7, the way it's written now is that the written informed consent is required for all treatment plans and procedures where a reasonable possibility of complication exists. So, what we're seeing a lot of is, blanket types of consent forms that really doesn't give the patients an opportunity to discuss their specific procedure being done, again, where a reasonable risk of complication can exist. But, if anything, just to clarify, but not necessarily the need for rule change, if there are unintended consequences to this.
Very good.
Thank you.
So there's no recommendation to approve by the board. Any discussion by the board? Any questions? As you said, legal will review this, look into this a little bit further. So seeing no further discussion, Dr. Yu.
Did we lose Dr. McNeil?
Looks like he just joined back.
He's just trying to come back.
Okay.
Thank you. Committee recommendation on possible action, currently proposed rule, Texas Administrative Code 111.5. Dr. Yu.
Okay, so and thank you, Dr. Tillman, for that segue. This has already been published in the September 11th, as of September 11th of this year, in the Texas Register, and it has not changed from our committee on e-prescription waivers. And if Ms. Stutter can talk about this.
Yeah, so this rule is currently up for adoption at this meeting. It was proposed at the last meeting. We did receive one comment during the comment period. It was from TDA, who provided a written comment in support of the rule as proposed.
Very good. So we have a recommendation to approve coming out of committee. Doesn't need a second. Any further discussion? Seeing none, Dr. Kirsch.
Dr. David Tillman.
In favor.
Dr. George Kirch in favor. Ms. Lois Palermo.
In favor.
Dr. Brian Henderson.
For.
Dr. David Yu.
In favor.
Dr. McNeil, is he back with us?
I'm going to abstain since I didn't hear the prior conversation.
Okay. Dr. Linda Burke.
In favor.
Miss Lori Jones.
In favor.
Dr. Margot Melcher.
In favor.
Mr. Rodney Bustamante. And Mrs. Catherine Sisk.
In favor.
The motion carries with 9 votes and 1 abstaining.
Thank you.
Thank you. This concludes Dental Practice Committee. Thank you.
Thank you, Dental Practice. Thank you, Dr. Yu. Great work. And as before, we've got some homework for our licensing as well as us. So the work continues. Dr. Henderson, welcome.
Thank you, Dr. Tillman.
Yes.
Thank you.
So
as far as the anesthesia committee report on the next agenda item, I want to thank my committee that met yesterday, Dr. Yu, Dr. McNeil, Dr. Burke, and of course, Dr. Tillman. Shall we wait on Dr. McNeil to be able to join us for this? Or
Dr. Henderson, I have audio.
Very good. Well, that's even better. I'm glad you're with us, Dr. McNeil. We kind of had a very easy committee meeting yesterday. Just a couple of things that are on the agenda. We discussed and made notice that the jurisprudence exam for anesthesia that's under Senate Bill 313 is up and running. We rolled that out from the agency. I want to recognize the attorneys and the agency, Ms. Mendez, getting all that put out. There were a couple of committee members that had taken the jurisprudence exam. There was some feedback on that. There were 100 questions and an 80 score is passing. So any comments or questions by board members regarding that agenda item?
So initially there were some challenges getting into it. Have those been resolved?
Had no problem getting into it. I'm going to ask Ms. Mendez, are there problems with people getting into the jurisprudence?
Access.
I hadn't received any notice from anyone about having any difficulty getting into the exam.
Okay, very good. That was just some reports I had heard. Dr. Kears.
I've got a quick comment. I did take the exam for level 1. It is a tough exam. I will tell you, you had to really pay attention and concentrate through it. And I'm proud of the committee's work on this. Y'all did an excellent job.
Well, I would like to say the committee really had little to do with this exam. The agency put this thing together and it rolled it out very smoothly. So I'm going to pass that accolade on to the people that deserve it.
Thank you.
Thank you, Dr. Kirsch. Our next agenda item that we discussed was the Advisory Committee on Dental Anesthesia 2020 report. They met, I believe, on the 14th or so. And I'm going to ask Ms. Studdard to briefly give the board their report and comments regarding that committee meeting.
Okay, well, the anesthesia committee did meet in October. They did draft a report, which is in your materials and will be also posted on the website for the public to look at. They did make a handful of recommendations for the board to consider, and they also found some trends after reviewing the data. And I can go over that, Dr. Henderson. Did you want me to touch on those?
Well, since our committee made no action with this, I'm going to leave that latitude to either the board or yourself. It is going to be posted on our website. It is also in your packet, so we can discuss that both as a committee chair and or as a board if members have questions regarding that.
Very good. Anything else, Dr. Henderson?
So no further questions regarding the 2020 report. Our next agenda item that we discussed was the stakeholder committee meeting, our stakeholder meeting that we had regarding the discussion of Halcyon. And I'm asking Ms. Studdard to give us a report of that stakeholder meeting, which led to our agency staff proposed rule of 108.7.
Okay. And yes, I did go over the comments that we received at the September 11th stakeholder meeting. And so I'll go over those this morning as well, because not every board meeting or member was at the anesthesia committee meeting yesterday. So we received a handful of written comments as well as oral comments. And so bear with me, I'm going to go through those. The first set of written comments, the first comment that we received was from Dr. Luce. He stated if there are examples of patient harm from outside the office use of benzodiazepines, he's in favor of considering methods to improve safety. In the absence of examples of harm or near harm, he's not in favor of altering the rules away from the ADA guidelines or FDA approved package inserts. Our next written comment came from Dr. Chad Evans. Dr. Evans was opposed to the board creating additional authority as it relates to sedation. As sedation was already recently addressed by the board, he believes there's no need for additional sedation authority, especially if there's no evidence of a threat to the public. Next written comment was from Dr. Jay Littlefield. Dr. Littlefield is opposed to eliminating a dentist's ability to prescribe triazolam outside the office before a visit. His reasons for opposing any rule changes include there appears to be no evidence of adverse outcomes. Patients will get more anxious if they're required to sit in the office until the drug takes effect. Unintended consequences can occur, such as patients will be given alternative drugs with longer half-lives. He suggests in lieu of eliminating a dentist's ability to prescribe or administer preoperative medications, that the board require that all dentists who prescribe triazolam preoperatively or at the office must have a sedation permit. Dr. Radwanski submitted a comment on behalf of the Texas Academy of General Dentistry. The AGD isn't aware of evidence of patient harm attributable to the prescribing or administration of benzodiazepines for anxiolysis, either in or out of the office. Dentists are already required to follow standards of care for all prescriptions, whether they are prescribed out of the office or administered in the office. It's AGD's position that there shouldn't be additional regulations on the prescribing of medications. Dr. Stephen Britton submitted a comment on behalf of the Texas Society of Periodontists. Dr. Britton stated he's not aware of any reports related to patient safety using benzodiazepines. He stated rules following for prudent use of sedation techniques already exist. He stated it will only limit the ability of safe providers to use their own clinical judgment for each individual patient. The TSP feels there's no need to consider a rule change related to this subject. Next comment came from Dr. Patel. He stated with clear recommendations of 1 MRD for anxiolysis versus 1.5 for minimal sedation, he doesn't see a need for further regulation.
Yeah.
Next written comment we received was from TDA. TDA is hesitant about the board taking any regulatory action that deviates from the dosages approved by the FDA and found in ADA or in FDA approved drug labeling. TDA understands that the non-sedation administration of anxiolytics and analgesics by dentists without a sedation permit is allowed by law, but does present a unique situation for the board to regulate. TDA is open to future discussions and deliberation on this topic if data-supported patient safety concerns warrant it. These discussions should potentially include defining anxiolysis in statute or board rule to give dentists a clear understanding of when anxiolysis may become sedation requiring a permit. Additionally, TDA is open to future discussion and deliberation on whether the board should amend Rule 108.7 to define the generally accepted standard of care and minimum requirements when dentists without sedation permits administer benzodiazepines for anxiolysis. TDA also understands that for most benzodiazepines currently on the US market, their use for preoperative sedation of dental patients is off-label, although it is professionally acceptable. The dosages recommended by the manufacturer for indicated uses, as well as the MRD dosages, appear to continue to be safe when used in dentistry, especially in the context of the recently revamped sedation permit rules and an increasing emphasis on patient monitoring and rescue should an emergency occur. One other written comment that we did receive that I didn't mention yesterday was from the president of the Texas Academy of Pediatric Dentistry. The Texas Academy of Pediatric Dentistry requests the board to prohibit dentists from prescribing benzodiazepines to children out of office, or to children for out of office administration. There were several oral comments made during the stakeholder meeting. The first one was from Dr. David Roberts. He stated, if there's no evidence of patient harm, then no regulations are needed regarding this topic. He commented that he agrees that Halcyon is not an anxiolytic drug. Dr. William Steinhauser was present on behalf of Texas Academy of Pediatric Dentistry. He stated that the standard is that a dentist should not administer drugs to children for sedative purposes outside the office. And he said that they asked the board to prohibit dentists from prescribing benzodiazepines to children for out-of-office administration. Dr. Britton, on behalf of TSP, reiterated his written comment and also discussed the MRD dosage requirements for minimal sedation. Dr. Wadwanski, on behalf of AGD, also reiterated his written comment. Dr. Canfield made an oral comment. He stated that all sedative or anti-anxiety medications should be administered in office only and should be administered by a dentist with a sedation permit. All patients respond differently to medications. What's anxiolytic for one person is sedative for another. He commented that Halcyon is not labeled as an anxiolytic drug. Dr. Evans was present during the stakeholder meeting, and he reiterated his written comment.
Thank you, Ms. Studdard. Board members, any questions for her regarding the stakeholder committee? Yes, Dr. Kirsch.
I've got a question. So in reviewing the rule 108.7, the major change is if you were a general dentist without a permit 1, 2, 3 license or 4, you could administer Halcyon. With this rule change, now you must have a minimum of a level 1 to be able to administer the drug. Is that correct?
That's correct. And when we haven't really actually got the rule proposed, but yes, the suggested rule.
The rule change, yes.
The intent of this is really having Halcyon become a controlled substance as a permit-only drug because of its off-label use and non-anxiolytic category. The other anxiolytic category drugs, Xanax, Valiums, an unpermitted dentist may continue to give that anxiolytic by statute, but this rule basically is saying Halcyon is a sedative and you must have a permit to administer it.
Thank you for that clarification. It seems like our stakeholders have a mixed review on this.
Well, I was really surprised at the stakeholder meeting, the more consensus that most people are only administering Halcyon in the office, and most all said they had a level 1 and felt everybody who had a level 1 should have a level 1 in order to administer Halcyon.
Perfect. Thank you.
Dr. Melcher.
Dr. Henderson, question for you is, are there any other drugs similar to Halcyon that would need to be noted on this exception or on this thing that we're trying to put in there?
Well, so that's a really slippery slope. And then just to tell you, it's kind of like one of the stakeholder threw out Remimazolam, which is only an intravenous administration benzo right now. But could it become a tablet? Yes. And by package insert, it says it has to be administered by anesthesia providers. It would be very similar to Rohypnol if it ever came available in the United States. It has anxiolytic properties, but it's really more of a sedative or an amnestic. So it's really difficult when a drug has multiple actions to say which one is really the one people are using it for. And it's because by statute, anxiolysis or anxiolytic drugs and analgesic drugs, a dentist can prescribe without having a permit. What we're saying is that Halcyon is a sedative more than it's an anxiolytic.
Thank you for the clarification.
Welcome. Dr. Yu.
Well, and just to clarify, Halcyon is labeled as a sedative, and that's why we're focusing on that. And, you know, I do agree, and I'm definitely in favor of having a level permit holder prescribe Halcyon because they have the additional training and out of safety. I am a little bit concerned about overreach in terms of telling, practitioners how to practice and how to, prescribe these things. But I do agree that, it might be good to have this out, have stakeholders take a look at the actual proposed rule, and maybe even get it to the governor's office and kind of see from there. But yeah, that's kind of my comments on it.
Thank you, Dr. Yu. Ms. Jones?
Is there any need to clarify trialkylam as well?
Putting Halcyon cost triazolam, because if you're not prescribing the brand name, you could get around that. That's probably a good suggestion when we get ready to consider this in the rule change. Dr. McNeil.
Thanks, Dr. Henderson. Part of how this had come about is reviewers were having some challenges as they looked at standard of care violations. And so that's where there was a need, and through the disciplinary review committee, just to have some clarity for the DRP members, but also for our licensees. That's why I think it's important for us to give some sort of answer. As Dr. Henderson said yesterday, and it was sort of talked about today, most of us certainly appreciate that it is a bit of a different type of drug. This is a sedation drug. It's being taught as a sedation drug throughout Texas and throughout many states in the U.S. To address the issue of patient harm, because I think that's what it comes down to, and certainly us as a board, if you look at the FDA insert on this and the warnings from the FDA on this specific drug, talks about things like sleep driving, because it's a little bit of a different beast versus something like Valium. People get in their cars and just start driving and they don't remember it, and there can be harm from that. You can have anaphylaxis, and that's an FDA warning with this drug. One-time single dose anaphylaxis. They talk about angioedema, tongue swelling, loss of airway. They also talk about gait disturbances or ataxia. You take this and, in my office, when we administer it, we're making sure that they're ambulating with assistance, they're in a wheelchair. If it happens at home, someone falls and breaks their hip because of that drug, are we going to get a board report on that? I think in a lot of cases we would not. People would not self-report that type of injury. But once again, from the FDA level, we know something like that is happening. It's also one of the FDA warnings is concomitant use of Halcyon with an opioid can certainly be a challenge. And it actually specifically talks about increasing drug-related mortality with that. Patient shows up in my office before I administer Halcyon, I get a chance to eyeball them to see their level of sedation as it is, if there is concurrent use of opioids. You don't have that ability if they take it at home. So I think from a patient harm perspective, there's certainly issues out there. I share Dr. Yu's comments there that, we need to give some clarity to our own people with respect to this, and let's hear what the formal comments fall down the road. Thank you, Dr. Anderson.
Thank you, Dr. McNeil. Dr. Burke.
Thank you, Dr. Henderson. I just wanted to make a few comments for the board members that weren't on anesthesia committee yesterday with us, because one of the things we discussed was the effects that administering a benzodiazepine, and in particular in this case, the Halcyon, to children outside of the office. We talked about how dangerous it can be for children, because we're actually asking the parents to do an assessment on the child ahead of time, and we're expecting that the parents are going to be able to administer the right dosage at the right time, so that when we see the patient for treatment, they're at their peak level. And that is just asking a lot of a parent that's not trained. So as a pediatric provider, I strongly feel benzodiazepine should only be administered in an office setting by a trained, licensed dentist that is a sedation permit holder. And that I think is very important. And one of the things later that we can discuss, I just want to make sure that we actually specify and say that our preference is not to allow children to be sedated outside of the office. But that's the end of my comment. Thanks, Dr. Henderson.
Thank you, Dr. Burke. Dr. McNeil.
Point of clarification on that last comment. Don't we have something in effect there right now, 13 and under or under 13, or is it just by following the AAPD guidelines?
Dr. Burke.
Dr. McNeil, what I'm referring to, when we kind of wrote out our rule yesterday, I feel it's a little vague. We didn't quite specify that our preference would be because we were talking about shall and should, and I just don't want there to ever be any confusion to think that in a certain situation it's okay to sedate a child under the age of 12 outside of the office. I just don't want to leave leeway where somebody can say, well, it did say shall, should, that type of thing. And I know we're not quite there yet, but.
Thank you, Dr. Burke. And I'm going to reiterate, and I'll probably ask Ms. Studdard to verify my statements. What this rule is really saying is that we're going to basically make Halcyon a permit requirement to administer. As far as sedating patients, statutorily, right now, a dentist can give anything anxiolytic to anybody. It's quiet on where that is applied. But when you get into the anesthesia practice of the rules, starting with the level 1 permit and higher, we refer to the current rule as following the AAPD guidelines at 13 and under. It's not a must, it's a should. And in that, your guidelines at the American Academy of Pediatric Dentists say do not sedate children outside of the office. So in a way, it's already there. As been stated multiple times by me, a licensee wouldn't know what those rules were if they didn't go to the AAPD guidelines to determine what they need to do if they're treating someone. That's why it would be really nice to have it verbatim in the sedation practice of 110 rule so that this discussion doesn't come about. The should that's put in the 108 standard of care is really talking more about, because at one time it must be, I think there's probably some comments and some people with special needs patients. I personally feel even adults shouldn't be sedated outside of the office. I mean, how do you know they're good if you don't take preoperative vital signs? But there's probably a few exception cases where certain patients of special needs might need to be sedated in order to help manage them to even walk into the office. So that's why I'm not real strong of making it an absolute.
Thank you.
Any other board members discussing the stakeholder?
Let me share. Just a quick question. Dr. Henderson, my computer's gone. So if you administered in the office 0.5 or whatever, gave the pill, you would be required after about 20 minutes to monitor, or how does that play itself out in your office?
Well, it's a good question. In my office, it goes with a needle or injection, but that is an ongoing discussion with people that do that. And I'm probably going to ask Dr. Burke, what is her policy with a young child that she sedates and when she actually puts the monitor on? Some people say we wait until the drug's fully absorbed and peaked in order to really do that. And other people say, well, every minute that they're absorbing it, we need to be monitoring. So I'm going to let Dr. Burke answer that question.
Okay. What we do typically, what's the standard of care now, is to take your preoperative vital signs before administering any type of a sedative agent to your patient. And we actually keep our patient on a monitor the entire time once they've taken a sedative until the time that we're going to go ahead and recover them and discharge them to their parent and so, or caregiver. But I just think with children, that's an important thing to do. And that's why when you start talking about sedating out of an office, and I agree with Dr. Henderson, whether it be an adult or a child, there's just not a way to know exactly if the patient's having any congestion, any wheezing, are they febrile? All of that has to be looked at before determining whether or not you're going to administer medication. But definitely, I think you need to keep monitors on the patient before you sedate and during the entire process. It's very important. And that's what we do in my practice. And I'm sure most pediatric dentists that are board certified are doing the same. Did I answer your question?
Well, I was asking about the adult. I don't administer to children. I've seen
an adult in over 25 years. I'm kind of older, but I haven't seen an adult in a long time. But I don't know, maybe Dr. Yu, do you do any sedatives?
Yeah, thanks for that. Yes, sometimes I will do oral sedation on patients that request it. And we do have the patient come in, an hour early, and we, give them 0.25 to start with. And usually, you have to realize that the bioavailability of Halcyon is about 45% in about an hour. So, it's a relatively short-acting sedative, but usually at about 30 minutes, we'll take evaluate the patient, see if they need more. But truthfully, if a patient is that anxious, we're going to IV sedate them. I tell them that we're giving only an anxiolytic, quote, dose, and just to get them, at a sort of a relaxed level. But my intent is to never knock them out. We tell patients we are not going to knock you out definitely not with this, because the problem I have with any oral sedative is that it's so sort of dependent on how the patient responds. I mean, you can be over sedated or under sedated, hard to reverse them if I ever were to reverse them, I would start an IV and administer, Romazicon, for instance. So, to me, I know the MRD is 0.5, for instance, but the MRD for an elderly patient is 0.125. So, if you're cautious, you really won't run into trouble with it. But I agree that, you don't want a patient out there, on their way to your office, having any risk of, falling, getting in a car accident, and having the ride even have to lift the patient out of the car to because you don't know if they're a hyper responder, for instance. So, that's really kind of my protocol, is to administer in the office when oral sedation is there.
So, most clinicians, and I defer as far as the numbers, a lot of GPs are doing oral. So the IV option that you're talking about is not applicable. I've had great success, very predictable drug, Halcyon Trazlone, oral 0.5, and, we've had no ramifications. I haven't heard of any clinicians. However, I did have a conversation with a doctor last night, and there was a report of a situation exactly like you're describing, where a person self-medicated and did not follow the directive of having somebody else drive him, but drove themselves. A big concern. But I've never had that experience. I've sedated hundreds of patients successfully, but I think going forward, if we're going to do it in the office as a protocol, I'll probably monitor them about 20 minutes and then move forward, instead of having them come to the back and then, because when they come to the back, then I'm required to be there, even though they're not sedated, so it just gets real complicated, and my protocols are going to have to change if I'm going to do it this way, which is what's kind of the recommendation moving forward, it seems to me. So just some thoughts on personal experience, Dr. Henderson.
So Dr. Tillman, just to follow up with your statement, are you currently sedating your patients out of the office?
I'm giving them the drug and directing them to take the pills, or depending on 0.25 or 0.5, an hour before the procedure. When they get to the office, we'll bring them to the back and begin monitoring.
And so in this regard,
I'm leaving it to them when they take it, but requiring that they have a somebody to take care of them.
So you would say the majority of general practitioners do that?
I don't know that. Indirectly, I've had conversations, and most people do that. They give them the drug through the pharmacy and direct the patient to have an escort, drive them in, walk them, escorted up into the office. And I haven't done any data collection, if that's what you're asking.
So I agree with your analysis that most general practitioners probably do practice that way currently. But I know some that are selective. So when they have the really old person that they're concerned about, they may bring them in. But the perfectly healthy 20-year-old that's strong and they want to give a pill of Halcyon, they'll give it to them. It's no different than home. And that's kind of where the should comes in. That let the practitioner make a clinical decision on who might be a good candidate and who's not. But I wanted to hear your comment. In reality, what we're really not doing as far as an adult population is saying that you should do it in the office. And I think it's most standard, even in most CT scans in hospitals. If you needed a little sedation to go into an MRI tube, they're not going to give you the pill outside of the MRI set. They're going to make you get it inside. And that's not even getting dental work done. So we're kind of a little behind our medical colleagues about if we're going to give a sedative to somebody, we're going to do it inside of our clinic. But it's something for you to think about. I mean, we gave Halcyon. I gave Halcyon like it was candy as a pre-med. But since AAPD changed their guidelines years ago, I've basically eliminated any preoperative medication in my practice, just because of the issues that you're talking about. But we're basically saying a Halcyon, you have to have a level 1 permit. And that's really a little bit different discussion where we're going with this than what we're really putting this in by rule.
Thank you.
Dr. McNeil.
Okay.
Dr. McNeil?
You know, I have a comment and then I have a question for Ms. Sisk if she would be open to answering the question. My comment is, you know, does it pass the smell test where if you take a Halcyon pill at home, you do it on your own, and then if a dentist gives a patient a Halcyon pill in their office, then we're obligated to put them on monitors and do preoperative checklists and all this kind of stuff. It doesn't make sense that you do one way, then the other way. And if we think it's fine for them to take it at home, well then, heck, don't monitor in the office. It seems as though it's a philosophical discussion there. A equals B equals C. For Ms. Sisk, as you hear all of this kind of being talked about, do you have an opinion about patients being sedated outside of the office?
I can give you my experience if you'd like that. When I had oral surgery implants, I was given the medication to take outside of the office. And then when I went in at the appointed time, then I was put on monitors. So my surgeon did both.
And just to back that up, in my own practice, I used to use Valium pretty frequently as a preoperative sedative agent. And I found, at least in my hands, it had a better margin of safety, and I had less challenges with some of the adverse reactions of Halcyon. I've had patients come to me who've had Halcyon from their prior dentist. They ran into an issue, had to come see me that same day. And I've had 2 patients actually be aggressive towards me based on the Halcyon. So I'm not sure which drug you did have. Maybe you had Halcyon, maybe you had a different one. And there can be a role for preoperative sedation. And that's why I like the direction Dr. Henderson's going. You know, we want to have clarity, and everything's fine until it's not. If you give a patient triazolam and they combined it with opioids and you were not aware, or they obviously didn't tell you they were going to take both at the same time, and the patient has a mortality, then you're going to have to defend your decision to give that sort of sedative agent outside of the office.
If I can add one thing to that, Dr. McNeil, I think at some point you have to depend on the patient to take care of themselves a little bit. You know, you can give them the instruction, and they may not follow it at all, but it's up to them to do that. Yeah, you're going to get the brunt of it if they come into your office all, you know, messed up on the drug that you gave them in addition to what they have. But I just think there's a point in time where you really have to depend on the let the person take care of themselves in some way. You know, give instructions, you take the pill, you bring a person with you to take care of you and to drive you, then that's what you need to do. Follow the doctor instructions. Right.
So, Ms. Zisk, on this, do you think this is over-regulating by what we're doing, or do you think what we have is currently?
My opinion, I've heard both ways that you're doing it. And it doesn't, you know, I don't feel that there's an over-regulation. If you feel that your patient, if you know your patient, you feel your patient needs to come in to take that pill and then be monitored in the office, then that's your call, I would believe. Because my doctor knew me, and he gave me the sedative or the drug to take outside the office. So I think it's I don't know which way is the best way to do it. I don't think it's overregulation to have somebody come in and take the pill and sit there, quite frankly.
Thank you.
If it err on the side of caution.
Yeah, I appreciate your participation and comments, very much so.
Dr. Yu.
And just to bring this up, just and I know it's been mentioned about the rule of unintended consequences, because, you know, if let's say, you know, they're required to administer Halcyon out, you know, in office. Now, you know, a lot of dentists do not have an extra operatory to let the patient sit. Are they going to sit in the waiting room? Are they going to sit, you know, somewhere else where they may not be, it may not be a safe area for them to wait? Or, you know, whether if they don't have the room to allow the patient to sit in an operatory for an hour before the procedure, you know, why not just prescribe something else, like, you know, Bob's or Dr. McNeil's Valium, you know, which has longer metabolites and, you know, will last a lot longer for the patient. So, you know, I'm willing to have this out and, you know, with stakeholder comments, but, you know, we just have to look at all aspects of this. Thank you.
Dr. Yu, any further comment from boards? Okay, well, let's move on to the Ms. Studdard. Came out of committee. It's a little bit different than what is posted on your website. So I'm going to ask Ms. Studdard to read that. I also would like to, it came out of committee with a 4-1 vote, 4-4, 1 against, to adopt the wording that Ms. Studdard's going to read. I do want to recognize or admit that Ms. Jones' comment of adding the parentheses triazolam inside where Halcyon is written for the generic would be a very friendly vote, but I think we have to vote on this and make the changes and go forward with that as far as order. Ms. Studdard?
The rules that came out of committee that is going to be proposed is that each dentist shall hold a level 1 permit, open parentheses, minimal sedation permit, close parentheses, issued by the board before prescribing and or administering Halcyon, and should administer Halcyon in an in-office setting.
Thank you, Ms. Studdard. So it came out of committee with this. Needs no second. Dr. Tillman?
Any further discussion? Seeing none, let's have a roll call, please, Dr. Kirsch. Oh, I'm sorry, Ms. Jones. And then we'll have a roll call. Ms. Jones.
So can we amend it at this time to include the word triazolam?
If we amend it, it will not be the committee's recommendation. We can do that as a board.
Isn't that just an editorial point of clarification, since that's just the generic?
It's the same thing.
I'll leave that to you.
As presiding
I would
officer, accept it as an editorial change.
I wouldn't have a problem with that either.
Yeah. Okay. So is that the desire, your desire?
Yes. So I would like Ms. Studdard, if it's privy to the board, to read the language coming out of committee and add the word triazolam after halcyon, or we could just substitute it either way because it is the same.
Yeah. Let's just add with a comment. Yeah. After halcyon.
Okay.
Okay. Go ahead and read that if you wouldn't mind.
Okay. So each dentist shall hold a level 1 permit, open parentheses, minimal sedation permit, close parentheses, issued by the board before prescribing and or administering halcyon, open parentheses, triazolam, close parentheses, and should administer halcyon, open parentheses, triazolam, close parentheses, in an in-office setting.
So there's the recommendation of committee. Doesn't need a second. Dr. Kirsch, roll call.
Dr. David Tillman.
Favor.
Dr. George Kirsch, in favor. Ms. Lois Palermo.
In favor.
Dr. Brian Henderson.
For.
Dr. David Yu.
Against.
Dr. Robert McNeil.
For.
Dr. Linda Burke. Dr. Burke.
For.
Miss Lori Jones.
For.
Miss Dr. Margot Melcher.
For.
Mr. Rodney Bustamante. And Miss Catherine Sisk.
For.
Miss Sisk.
She voted for.
For. Sorry. Yeah.
Okay. The motion carries 8-1.
Very good. Thank you, board. And Dr. Henderson, thank you for anesthesia's work. We appreciate you and your committee and some more good discussion as well. Dr. Yu.
Thank you, Dr. Dillon.
Just a quick clarification for Lauren and Cassie. This will go out to stakeholders and then the governor's office will look at this, right?
It'll go to the governor's office first for approval, and then if they do approve or don't have any comments for us, it'll be published in the register for comments.
Okay, just want to make sure. Thank you.
And I've got a revision on that motion. It passed 9-1, not 8-1. It was 9 in favor, 1 against. Yes.
Thank you. We have Continuing Education Review Committee. Dr. Burke.
Thank you, Dr. Tillman. So moving on to our Continuing Education Committee meeting, I would also like to thank my committee, which was Ms. Lori Jones, Ms. Catherine Sisk, Dr. Kirsch, myself, and Dr. David Tillman. The first thing we discussed was a CE provider application that I worked on with Ms. Mendez. And Mrs. Mendez, is there anything you want to say about the provider application, or I don't know if you're still there. Christine?
Yes, ma'am. I'm sorry. Yes, I'm still here. No, I didn't have anything to add to it. I think the final outcome was good.
Okay, perfect. And as a result of developing our CE provider application, we did determine that we are going to have our board staff research and look into Rule 104.2B, which actually will look at our CE providers annually to make sure that they're still qualified to continue as our CE providers. Ms. Studdard, do you have anything else to add to that?
No, that was the recommendation that came out of committee.
The next agenda item.
So it's not a motion before the board, so we don't have a vote on this, but we appreciate this recommendation being sent to staff.
Yes.
So continue.
Yes. So the next thing on our agenda was looking at Rule 104.1. And so I am going to now ask Ms. Studdard to cover that for us.
This rule was proposed at the last board meeting. It's up for adoption at this meeting. The committee did recommend to adopt this rule. It was regarding the human trafficking requirements that came out of House Bill 2059. The requirement that practitioners take this human trafficking course prior to renewal of their license. The board did not receive any written comments regarding the rule. One thing, we did have a couple of questions or concerns about how this course, what area it will be applied to, either the technical scientific requirement or the 8-hour risk management ethics requirement. And so this, the course, since the human trafficking course doesn't meet the definitions of technical or scientific, it will be applied to the 8-hour risk management ethics requirement of the rule. And I'm happy to take any questions about that.
Any questions, board? Seeing none, very good. So we have a recommendation by committee, doesn't need a second, to approve. Seeing no further discussion, Dr. Kirsch, could we have a roll call?
Yes, sir. Dr. David Tillman.
Approve.
Dr. George Kirsch, in favor. Ms. Lois Palermo.
In favor.
Dr. Brian Henderson.
For.
Dr. David Yu.
In favor.
Dr. Robert McNeil.
For.
Dr. Linda Burke.
For.
Ms. Lori Jones.
For.
Dr. Margot Melcher.
For.
Mr. Rodney Bustamante. And Ms. Catherine Sisk.
For.
The motion carries unanimously, Dr. Tillman.
Very good. Thank you, board. Dr. Burke, Administrative Code 114.12.
So our next agenda item and our last agenda item is looking at Rule 114.12, which is just the RDA component of the last rule we just adopted. So at this time, again, Ms. Studdard, do you mind reviewing that as well?
So like Dr. Burke mentioned, this there's a human trafficking CE requirement prior to renewal for RDAs. So this is going to be in 114.12, and this came out of the same House Bill 2059. The board did not receive any written comments.
Very good. So we have a committee recommendation to approve. Doesn't need a second. Any further discussion? Seeing, yes, Dr. Yu.
Just to clarify, the way it's written, the dental assistants will receive CE credit when they take this. Is that correct?
It's a prereq to renewal, so that they'll have to take this prior to renewing.
So this does not count for CE credit for ethics for the dental assistant?
No.
Okay.
Well, I mean, well, let's discuss this. So it's the requirement out of the bill was that practitioners have to take this prior to renewing. And so 114.12 lists the requirements for RDAs must complete at least 6 hours of CE.
Is it science and scientific and technical?
No, it doesn't specify.
Well, the statute says ethics. It should count for ethics, but the way it's written, it doesn't specifically say that it counts for anything as far as the CE credit.
Well, the ethics, the statute, that was for doctors, for physicians. Dentists, there wasn't a specific requirement for ethics for dentists.
Right.
Dr. Henderson, did you have a comment?
And then Ms. Jones.
So my comment is exactly what Dr. Yu is bringing up. I find it difficult as a board to say we're going to give an hour to the dentist and the dental hygienist for this course and not give them an hour of CE. So in essence, you've raised their CE requirement by an hour by not giving them credit. And so I think we have to say, is that okay? Is that what we really wanted, the intent, when everybody else is actually getting an hour credit for the course? So, and I think that's what Dr. Yu and myself are looking at.
Okay.
Ms. Jones?
And actually, Rule 114.12 says that the 6 hours for a dental assistant, the CE courses must be in areas covering dental assistant duties. So 3 of those must be in clinical CE.
Right, it does specify that 3 out of the 6 hours must be in clinical CE. So Dr. Yu, are you wanting this to be more specific?
Well, I just thought it would make more sense to mirror the dental assisting with dentists and dental hygienists, the way the rule is written for them.
Okay. So it's similar language. What part of the language are you not liking? 14.12C.
I think he just wants to make sure they get credit.
So those hours go towards your CE requirements for the year. Is that accurate, Dr. Yu?
Correct.
Ms. Palermo?
Yes, I do feel like they should get credit, just like the dentists and the dental hygienists. But I'm getting to the point now where I almost wish we had somewhere at the beginning, maybe of the continuing education section of the rules and regulations. It's getting confusing as to, okay, you got to have CPR, you got to have OSHA, they don't count for this. Now you've got to have an anesthesia one. Now you've got to have risk management. Now you've got to have this. It is getting really confusing for everybody to figure all that out. So if there's somewhere that you can just put that with, without all the extraneous language like the rules have, I think it would help a little bit.
Okay. Dr. Tillman?
Yes, and I've asked staff, IT particularly, if there's an ability to provide these for each clinician, because everybody's different, right? Some have sedation requirements and all the stuff. I mean, it just adds up, and you've got to keep it in your brain somewhere. If we can display it on the website, the state board website, or some other vehicle, so we could keep, so we could stay in compliance, that could really help us provide our services, in the way that the state asks us to do. So I don't know what's going to happen with that, but I think it would be beneficial if somehow we could track that through our website.
Okay, thank you. So, Ms. Stutter, do we need to change that? Are we going to need to modify that now?
I didn't know if Dr. Yu had any specific suggestions as far as modifying the language.
Well, I mean, if the intent is to allow dental assistants to have CE, which I thought it was, having it mirrored with the dentists and hygienists language, which says, I know that the dentist and hygienist language says as part of the 24-hour requirement, if we can just basically mirror that and say as part of the 6-hour or 6-hour requirement, etc.
And I think
that'd be part of the 12 hours. They have 6 a year. Don't they have 12 altogether?
I think it's specified in subsection.
No, it's 6 for 2 years.
Thank you.
The proposed rule does say as a prerequisite to renewal. And so I think that's sufficient.
Dr. Yu,
okay.
This language that you're requesting, maybe to give something a little more concrete, instead of how it's written now as a prerequisite to the renewal, you prefer to have as part of the 6-hour requirement, and then the rest of the rule is the same.
Right. I'm thinking of that because it doesn't specify whether there's actual credit for it.
Dr. Henderson.
So yes, and so we all recognize this human trafficking is a prerequisite for renewal for all of us, and that's really the intent. We're catching everybody. And in reality, we're also supposed to be doing anybody who works in our office, correct? Whether they're a registered dental assistant or not, because they work in the profession. But again, I'm going to leave that as a little bit of a comment. Is there any way on our license renewal registration, since we do it online, that there could be a link that says you need to take human trafficking, and it's a hot link that takes you directly there when you're registering? And that way would facilitate helping everyone who knows that they need to do that prior or as their application.
Yes, Dr. Henderson, that's possible. We can do that.
Good. That might help. Thank you for the suggestion.
That'll be good. Okay, is there any further discussion?
So we have a committee recommendation. Doesn't need a second to approve the committee's recommendation 114.12. Seeing no further discussion, Dr. Kirsch, do we have a roll?
Yes, sir. Dr. David Tillman.
In favor?
Dr. George Kirsch, in favor. Ms. Lois Palermo.
In favor.
Dr. Brian Henderson.
For.
Dr. David Yu.
Against.
Dr. Robert McNeil.
For.
Dr. Linda Burke.
For.
Ms. Lori Jones.
For.
Dr. Margot Melcher.
For.
Mr. Rodney Bustamante. And Mrs. Catherine Sisk.
For.
The motion carries 9-1.
Very good. Thank you, board, and thank you, Continuing Education Committee and Dr. Burke. We appreciate your efforts and move forward. Public comment. Do we have any public comment?
Yes, we do. We have a couple. I believe Dr. Radwanski is on the line.
Dr. Radwanski, welcome.
Dr. Radwanski, can you mute your YouTube feed? We're getting some feedback. Or pause.
That's it. Better?
Yes.
Yes, very good. Welcome. If you could keep your comments to 5 minutes, you are addressing the board. Go ahead. Doctor, are you there still? I can't hear them if I mute. Okay. Well, go. Keep muted, but Doctor, you're on, so you can speak and we will hear. Are you speaking? We can't hear.
Dr. Radwanski, you need to pause the YouTube stream.
Do that.
I can't hear them if I'm muted. Okay. Go ahead.
Just
keep muted, but Doctor, you're on.
Can you hear me now?
Yes. Yes.
Very good. Thank you. Thank you all for your patience with my trying to figure this out. And I'm speaking on behalf of Wayne Radwanski, so I'm a member of several organizations like most of y'all are. So, but anyway, I had a concern, and I think Dr. Yu kind of cleared this up a little bit when this was brought up about COVID vaccines by dentists, administering COVID vaccines by dentists in Texas, meaning it's a legislative charge. But it's my platform here to talk, so I'm going to talk a little bit about that if we can. And recently there was a survey out. I don't know if y'all saw that, but obviously our state board got involved in it of all 50 states did a survey on asking the boards if the dentists are going to be allowed to administer the COVID vaccines. And as of recent, 11 have said yes, and I think that's great, and that number keeps growing. The question was, it says, is your state or territory allowing dental professions to administer COVID vaccines to the public? And what kind of got my attention here was it said, our answer was, and I'm talking about Texas, no, and it's unlikely to change in the future. So like I said, I'm a member of many organizations just like you all are. And the ADA, particularly, and the AGD presidents have actually sent letters to the U.S. Health Department asking if we would be able to help out in this pandemic. There's a lot of, I would tell you that there's probably a lot of us dentists that like to help out. We're pretty good at giving shots. We do it pretty much every day. And I know there's some logistics involved in this as far as the refrigeration and all that's involved in that. But I think the government would help us out there. I say this because I was in the Coast Guard, believe it or not, 50 years ago. And when I got in there, they said we are under the Department of Transportation, except in times of war, which in times of war, we're under the Department of Navy. Well, I think we got a war going on here right now. It's called COVID. And I think we need to humble ourselves and jump in here. And if we want to call ourselves essential healthcare workers, we need to certainly step up and volunteer and help out. I mean, we've got probably average at least 20 people coming through our offices every day. And if we can help that out in the second most populated state in the country, I think we should be able to do that. And so I petition you to, you guys have better contact with the governor than I do, and the legislation, but that's one of the things I wanted to bring up. But there are a lot of Texans who are dying today. We lost over 3,100 yesterday. So vaccines are coming out real quick. We need to jump on this, and we don't need to put this off to board meeting in February or March. I mean, it's time for us to make a move if we're going to do that. So yes, there'll be a lot of dentists that don't want to participate, but I think most of us are willing to help out. This is what we're called to do. We're here to help, and we're here to serve. One last thing. I did have a question about COVID testing. Now, I talked to Ms. Studdard, or at least we emailed each other about the rules on that. Right now, it says that we basically aren't allowed to test. Now, my question is, we're not testing. I mean, if we bought an Abbott Now, antigen testing unit, put it in our office, yeah, that would be testing. But if we're collecting a specimen like saliva and sending it to a CLERA or a EUA lab, I don't see that as we are actually testing. So I just wanted some clarification from the board as to what you're calling testing and what you're calling collecting a specimen. It should be two different things here. So that's my question and my comments. So thank you again for all y'all do.
Thank you, Dr. Radwanski. Ms. Studdard, do you have comments or responses?
I don't at this time, since it's not an agenda item, but Dr. Radwanski, we can talk about this more, not during this open meeting. I can discuss further with you, but I would advise the board not to make any comments since it's not an agenda item.
Very good. Thank you. Any other public comments?
We do have Dr. Black from the Texas Tech University of Health Science Center.
Very good. So, Dr. Black, welcome. Are you there? You can, if you could unmute yourself
Yes, thank you.
Welcome to the board. We appreciate your time with us. We appreciate your service to get things up and running in El Paso. Tell us what's happening in El Paso, where you are, and kind of timeline ahead.
Well, thank you, David, Dr. Tillman. I'm happy to address you all. Greetings from far West Texas. This is the latest public dental school. That is the public dental school that's being built 50 years after the last dental school has been built in the state of Texas. The last dental school was San Antonio when Texas had a population of 10 million. This is a dental school that has been sponsored by Texas Tech University and is specifically designed to try to meet the needs of Western Texas and the borderlands. And that is certainly part of the mission of the Woody L. Hunt School of Dental Medicine. We refer to it now as the Hunt School of Dental Medicine, and that's what I will do for the rest of my comments. Only to say that we're very excited to be on a schedule that allows us to open in July of 2021. Our first class will be 40 students, and thereafter we will have 60 students. We are entirely 100% teaching pre-doctoral or training general dentists. We don't have the facilities, the space at this time to have the specialties. But we're very pleased to be joining what is an excellent group of dental schools, unmatched anywhere else in the country, I believe. We have excellent schools in Texas and A&M and the 2 UT schools in San Antonio and Houston. We are in the application cycle as we speak, and some interest I think of you all would be interested in. There's about 1,000 people in the pool. That is growing every year. We have already interviewed about 325 just for a class of 40. The applicants would really, as colleagues and those interested in dentistry, you would find them to be outstanding individuals. And it does your heart good to see the quality of people that are applying for dental school and the amount of accomplishments that they have done in such a short time. So we feel very good about the quality of student we're going to have. And I think the thing that we're most interested in is trying very hard to make sure that we have the right mixture for the first class, so we'll really set the tone for years to come here. The school is characterized by a very innovative curriculum. It's a case-based, symptom-based curriculum that is designed to prepare the students not only to take and pass and do well on the now single national board. This class will be the first class that there will be no National Board 1 and National Board 2. They will take what's called the Integrated National Board. And very important that the curriculum matches this. The three other, I think, interesting parts of the school's curriculum and the mission and vision of the school is that Spanish will be a requirement in order to graduate. We also are going to be issuing a dental public health certificate that involves the real core courses on your way to getting a master's in public health. We're not offering that now, but the students will have 16 credits in epidemiology, biostatistics, social determinants of health, etc., on their way if they wanted to then go ahead and get a master's. And I think that also teaching them that part of their practice, and it doesn't have to be here. We know that we're not going to keep all of our students in Western Texas, but part of your practice should be in helping the underserved and leaving this school with the idea that that is very important to a professional practice and to the citizens of Texas. Again, we're a public school. 90% of our students are required to be residents of Texas. Certainly the taxpayers through the legislature have seen fit to support us to this point. We are entirely accredited by the Commission on Dental Accreditation, as well as accredited by the Higher Education Coordinating Board. And our Health Science Center that we are in, that is small but growing steadily, is the second health science center that is a Hispanic serving institution, which we think is very important. So our mission specific is to be training healthcare leaders and to take care of and help improve the health of all Texans, including those in Western Texas and the border. I'll be glad to answer any questions that you all might have. Happy to do so. Can talk about this school until next week, or any questions at all.
Dr. Henderson.
Dr. Black, it looks like a beautiful day out there in West Texas. As a guy that's born and raised from out there, I'm glad you're serving our community. I do have a quick couple of questions. One, you said Spanish was a requirement. Does that mean you're going to provide Spanish curriculum for the students to learn, or they must already have it to apply?
No, it'll be provided in the curriculum for them, and they have an opportunity. For instance, they come in and they're an excellent Spanish speaker and can speak medical dental Spanish, that they can apply to opt out. But they're going to have to take a test to satisfy us that they are competent in Spanish. We're not supposed to use the word fluent anymore, because that can mean lots of different things to different people. So.
Yeah, I tell everybody I'm effluent in Spanish, so that is a whole new meaning. My next question, I also hear that you're looking for students who are going to stay and are required to stay in the West Texas community after graduation. Can you expand on, is that true, or is that just rumors that I hear?
No, those are rumors. We know that we're not going to keep people from, for instance, that are applying, that we may offer a seat to from East Texas or from Houston or Dallas. There are lots of talented applicants that come from those large cities. We are trying very much, and with Tech's influence, to select people that we think will return to an area that's underserved, or that are in rural parts of the state, which is a lot. You know, we have about 60% of our practitioners are rural, and we're not making any requirement at this point. We're going to encourage them, however, to practice in areas that certainly are underserved as far as dentists are concerned.
Thank you so much. Good luck to you.
Yes, sir. Thank you.
Dr. Meltzer. You're muted.
Sorry about that. Following up on Dr. Henderson's question about the just the Spanish prerequisite, you stated that y'all are going to test them. Is it a verbal test or competencies, or is it a written test?
It's going to be an online test that we'll select. I don't think it's going to be as tough as a Spanish interpreter's test, but there's several options out there. I think our home university, Texas Tech in Lubbock, has a test that they use, and I think that will be something that we'll look into a little further. But certainly when they come in, they'll be assessed by we have faculty that are going to teach the Spanish. Spanish is 1 hour a week for 2 years. And there'll be people that will need all of that time. And then there'll be people who probably would like to pass out of that and do something else with that hour.
I think that sort of just, I guess, where I question that is that, you know, we can do a test well writtenly, but when you get out there and you speak it, it can be a different story. I'm Hispanic. I don't, English is my first language. Spanish, I've had to take and I've practiced. And so it doesn't come naturally to me. And so I just sort of I was just questioning it because I could see where written they could do really well with the test. But when you're orally trying to interact or communicate with patients, it's a different story. And then the credentials of your faculty that are teaching this, what is that? Or what are their credentials?
Well, the credentials of the faculty that are teaching it are going to be, we're going to use folks from University of Texas at El Paso that are in the language department who teach Spanish on a regular basis. And I think your faculty is there to advise you to say, yes, we think you could probably take the test and pass out of it, or you're probably not ready to take the test. And that's kind of what you want from your faculty anyway, is measuring the competency of the Spanish speaking.
So thank you, Dr. Black. Tell me how you're moving forward with faculty selection, what that process is, where you are with that.
Well, I can tell you that it was always going to be the most difficult part. You don't recruit faculty early and have them sit around and do nothing before you get the students. But then when you're ready to recruit faculty, all of a sudden you're in a hurry. And COVID has not made that very easy. It hasn't been easy as well because El Paso has been in the news a little bit too much. So people are a little bit reluctant to come out here in person and meet with us. So we are going to have, with 40 students, I'm hoping that we'll have 20 to 25 faculty hired. We think we will. It's something that we work on 24/7 right now because we want to be ready. It will be clinical dentistry. It will be biomedical faculty, some deans for administration, but we're getting there. And we have already here at the Health Science Center biomedical faculty that if we had to fall back on them, we would use them, David.
Very good. So it seems like the location of El Paso, so close to Mexico, and there is not a requirement that the professor is state board certified, a Texas licensee. What is your thought process on who you're going to select or faculty individually that you're going to go after as it relates to state board certified or internationally, particularly Mexican?
We're not at this point interested in any kind of foreign faculty unless they are already employed at a COTA accredited dental school in the United States. We've in effect basically have a ban on crossing the border at this time anyway, but we have no future plans for that.
Very good, thank you. Any other questions by the board? So the building, it's been constructed. I assume the operatories are beginning to go in. Kind of where are you with the construction?
So we have two parts because, really we don't, we have a tuition revenue bond in for a formal dental school building to be about 220,000 square feet. It's the #1 legislative priority for this particular campus. We are in right now in an area we call the Dental Learning Center, which is about 30,000 square feet. That's where our simulation laboratory that's finished is, and our faculty offices and conference rooms and some educational rooms. We'll also probably share some rooms with the medical students as well. The clinic is about 100 yards from where I am sitting. And it is a building that's on the ground level, one story, about 40,000 square feet. 120 teaching operatories are located there. Another 25 special use or multi-use operatories. That is in the process of, now it's a little bit ahead of schedule. We're going to install the chairs, lights, and that kind of equipment in February. We expect that to be up and going in May.
Very good. So is it open bay, I assume, or individually? How do the clinics?
Well, it's 120 what we call teaching operatories that are reasonably open bay. We put in some extra protection due to some recommendations by the CDC. We have then 25 that are closed operatories. 6 of those are faculty practice. We expect to do well with all of the protocols. We've been fortunate. I think we've learned a lot from what the other 66 schools in the United States and Canada have done in regards to infection control. Our clinical dean, who's arriving soon, first week in January, actually is a national known expert in infection control, and we feel very good that this is a propitious time for him to be here.
Very good. Any other questions, board?
Thank you all. We appreciate it very much. We appreciate this opportunity to address you, and appreciate the hard work you do on behalf of practicing dentists in Texas. Thank you.
And thank you for all your work, Dr. Black. All the best. Have a great holiday.
Thank you.
Any other public comment?
There's still that Kelly Branch.
No other.
Okay, perfect. Agency reports. Couple of reports coming ahead with Letitia Capel. So Executive Director first, how is our ED doing? Just informally. I know I've heard some good reports.
Oh, well, thank you. I'm doing well, thank
you. Good.
I'm happy to report my son who graduated from Army basic training and is currently in airborne school, will be home next week.
Perfect.
For a short time, so we're really excited about that.
Neat. And Casey, how's Casey doing?
Casey's doing good. Her baby is beautiful.
Very good.
We cannot wait for her to come back.
I'm sorry, I interrupted your report. Go ahead.
No, that's okay. I appreciate it. First of all, I did want to thank Lauren Studdard for her hard work and dedication to the agency. I know she's been working really, really hard. So I did want to point that out to everyone that she's been doing an outstanding job and it is appreciated. So thank you, Lauren. I wanted to give a quick COVID-19 update. The majority of the agency continues to work remotely and we limit our time in the office when possible. Staff do follow safety protocols while they're in the office, including signing into the office for contact tracing in the event of an office COVID-19 outbreak. Thankfully, we haven't had any. All staff are also required to submit daily task reports while they work remotely, and we're working towards bringing additional staff to have the ability to work from home. One thing that I wanted to add was that there was a governor's call that I participated in this past Monday. And the majority of it was to talk about COVID. So the session is set to begin in January, in the middle of January. And at this time, there's no clear plan on how the legislative session will be held. But the governor's office did say that the key to this is to remain responsive and to be prepared for what may be asked of us. We still don't know whether staff is going to be asked to attend the upcoming meetings virtually or in person. So we have to be prepared for either one. COVID-19 expenses are tracked, and those are submitted on a monthly basis to the Legislative Budget Board. Let's see. For now, the agency plans to continue to conduct informal settlement conferences, committee meetings, staff and director meetings virtually via Zoom. Daniel Matthews with IT has developed written instructions for the agency's public commenters. So thank you for that, Dan. This past Tuesday, I had what I thought was going to be a full-blown audit with the State Office of Risk Management. It ended up being more of a meet and greet, a pre-audit meeting where we discussed the agency and what each of the divisions do. She also did a brief walkthrough through the agency. She did commend us on not having any workers' comp. We haven't had any safety issues as an agency. So she will return in March of next year, and that will be a full-blown audit, which entails going over our safety protocols, our HR manual, fire and safety. And I don't expect there to be any issues with that. I will update the agency after that audit. So back to the legislature, I participated in a joint budget hearing for Article 8 agencies back on October 29th. The agency presented a summary of the legislative appropriations request to the Joint Budget Committee. At this time, again, it's going to be a combination of in-person and virtual meetings. As a reminder, the exceptional item number 4 of the legislative appropriations request that was submitted is expected to change once more information and quotes are received from the Texas Facilities Commission. There are several things that the agency asked for, and until the construction portion of the Facilities Commission is able to give us more concrete quotes, we won't be able to update that. So we did go ahead and alert the Legislative Budget Board, the Comptroller's Office, the Governor's Office. Everyone is aware that more than likely that figure will change as soon as we get more information. And we're not the only agency. All of the agencies that are moving to the new building, which is the Bush building, are in the same predicament at this time. So, and then one thing that I did want to point out that the board members may not be aware is that as an agency, a couple of years ago, when the human trafficking began to, we had a visit from the Office of the Attorney General talking to us about the human trafficking. At that time, it was a video that was presented to us, and voluntarily our agency implemented that all current staff at that time, and then now all new staff prior to beginning work with the agency are required to view the video. So I just wanted to go ahead and put that out there. So it's not a, we're not required by the state, but as an agency, we chose to go that route. And that concludes my acting executive director's report. If anyone has any questions.
Any questions from the board? Dr. Henderson.
Ms. Capel, I just wanted to thank you for your participation and filling in when Ms. Nichols is out on vacation. I want to let you know I feel really good with you and Ms. Studdard in control. Thank you so much.
Thank you.
And I would echo the same regards. It's been seamless. It's run. We miss Ms. Nichols, but it's been running very well. So we appreciate your hard work.
Thank you. I appreciate it as well.
Seeing no other questions, this concludes the executive division report. Now, typically we take a lunch about 12:30 or 1. If I could have 15 minutes to stretch my legs between the executive director report and the finance administrative report, with the permission of the board, we could probably finish this up in pretty quick order. But I would ask that we have a 15-minute break. I have 12:54. If we could reconvene back at 1:15, I will call a recess. So I have 12:54 and we'll reconvene at 1:15.
Dr. Yu, how is your turtle doing?
Turtle's still alive.
I was going to say, is it growing any?
Not really. I mean, the thing is, it only grows, you know, the males grow up to about 4 inches and the females about 5 to 6. So they live up to 75 to 100 years.
Wow.
Which is crazy. So,
so are you getting another one?
I would love to breed and you know, try to propagate that species and hopefully, you know, donate to zoos and such.
Oh, that would be neat.
Yeah, it's kind of hit and miss on whether you get a male or female, but we want to, you know, make sure this one survives first.
So how's your wife's garden doing?
Oh, it's good. I mean, she has a whole section to, you know, for the tortoise.
I wondered how the winter weather was gonna mess with their garden.
Yeah, funny you should ask, because we harvested pretty much all of it, and we're just drying it out and freezing it.
I was going to ask if you could freeze it and then thaw it out.
We're trying to get them to eat the dried up, you know, plants, but we'll see, you know. But he's really cute.
So what did they finally name him?
They're unmuted now.
Okay, board, just a clarification. So everybody knows about the turtles. But are we getting back, everybody? Ready for one last push? So I do have 1:15, so as soon as we get... Okay, so I will reconvene for the last leg. I have 1:15 p.m. and I appreciate you, board, and hopefully we'll get finished in quick order. We were talking with Ms. Keppel, so we had an executive director report. We'll have the finance report now. So Leticia, if you would want to continue.
Sure, thank you. I have uploaded the fiscal year 2020, which ended August 31st of 2020. I have uploaded those reports for your review. If any of you have any specific questions for those performance measures, I will defer probably to one of our directors. So if you've had a chance to review and you have any questions, please let me know.
So we have, there's no audits currently going. We're clear. Tell us where we are with that.
Right. As far as audits, no, we don't have any.
Great.
I've received an email this week as well. There's just an update to the comptroller audit, and what happens is we're audited, and then the report comes out, and then the agency responds to the report, and then the comptroller checks in again to see how things are going. And we've already, that's where we're at right now. And I just received an email this week to respond again. But we haven't had any issues. Anything that was suggested to us, we went ahead and implemented. We provided proof of any questions that they had. And so there's no issue. And then the only upcoming audit that I'm aware of at this time is that State Office of Risk Management audit that I mentioned earlier, and that will be in March.
Very good.
Okay. Next, I've uploaded the usual reports, which are the fines that we receive on a monthly basis, and then the DRP report, and lastly, the agency budget. Everything looks good at this time. One thing that I forgot to mention, but it is finance related, so I apologize, I didn't mention it in the executive director report, but since it's finance, I will mention it now. The peer assistance update, the Professional Recovery Network, last fiscal year, we did receive a loan from the governor's office that has been repaid.
Wonderful.
That has been taken care of. And also in response to that, so that the agency does not end up in the same predicament as it did previously, this October 1st, We did change our peer assistance fees to better reflect the biannual renewals that came from Senate Bill 313. And so we are now in line and we do not expect any deficiencies.
Wonderful.
For that program.
And they've been paid and everybody's good.
Everybody's good.
Yay.
Yes.
Ms. Capel, can I ask you a real quick question?
Yes, of course.
What we appropriated for this year's budget, was it $4.5 million? Is that right?
Yes.
Okay.
Yes,
I'm reading that. I want to make sure I'm reading that right.
Yes, it's $4.5 million. But also keep in mind that the peer assistance is included in that, and also Texas Online. And with both of those funds, the Texas Online is $250,000, and then the peer assistance is $132,000.
Right.
Those are fluid, and what that means is that we don't receive those funds up front for either one of those programs. What happens is that as licensees renew their licenses, we collect that money and then turn around and pay it out on a monthly basis. So those are contingent on what comes in and varies from month to month.
Right, thank you. Out of curiosity, how many licensed dentists do we have in the state of Texas?
Ms. Mendez?
Is it 16,000? Yes, between 15 and 16.
Between 15 and 16,000?
I think my recollection.
I'm just curious. I don't need an exact number. I was just curious.
17,000 it was our target for 2020, but that was that. You have to remember when you look at those numbers, at those targets are based on annual renewals versus the biennial renewals that we're on now. So the numbers skewed a little bit, but Ms. Mendez, when she gives her licensing division report, will be able to give you that exact number.
Right. Thank you.
You're welcome.
Great job, by the way. Thank you.
I appreciate that. As far as our budget is concerned, we're right on track. We are a little more than a quarter through this fiscal year. Things are looking really good. As a reminder, the governor did mandate that agencies return 5% of the current biennial budget. And what that included was funds from the fiscal year 2020, which was last year, and then the current year. Unfortunately, because the majority budget comes is salaries, we were forced to do a reduction in force, so we did lose some staff there. The good news is that we were able to return more than we originally expected for fiscal year 20. So that opens up our budget a little bit more. I'm still approaching it in a very cautious manner because there is always that possibility that if the economy does not recover as expected, there is that chance that the governor will ask for more funds.
Sure.
So,
Jeez.
Dr. Henderson.
Ms. Capel, excellent job. And so you hit on a couple of my points that I was going to ask you about the budget. One, with the loan being paid, I don't see a dramatic impact in this year's budget. And I'm going to assume you paid it out of this year's budget, not last year's budget.
No, we actually paid it out of last year's budget.
Oh, good. Even better. So that's why I didn't see a major reflection here. And then this budget does include the 5% that we've already returned.
No, it does not. We won't actually return that until the end of the year. At least the agency hasn't received any direction to do that. That might certainly happen once the session starts. There is that possibility we'll receive that directive where they'll want the money up front and we'll make the entries to make that happen. But for fiscal year 2020, we lapsed the funds or returned them to the state.
Okay, thank you. Answer my question.
So we would return about 228,000. Excess collected. We collected in excess to basically $250,000. So that's going to be almost a wash.
Well, the 5% that was asked of us for this biennium was $376,000.
Oh, wow. Boom.
Ms. Capel?
Yes, ma'am.
So the money that we have saved from not doing any in-person ISCs or board meetings, all those expenses that go along with it, where is all that money being accounted for? And would that not be helpful for paying these other things that we have not paid?
Yes, exactly. And so a lot of those funds, the majority of, in fact, all of those funds where we didn't spend the money on the normal travel, we didn't send our investigators out for many months. I don't think they went back to investigating out in the field until July. All of that savings was returned back to the state. And so that's why I mentioned that instead of the lower figure that we originally planned on returning actually became higher. So we were able to give more of that 5%, more of the $376,000 in fiscal year 20, because the majority of it was going to come out of this current year, and it won't be as much of a burden for this fiscal year as we originally thought.
Good.
So is that something that maybe you foresee for maybe next year? Not necessarily for the board meetings, but I think for ISCs is maybe, we continue with this virtual meeting just to help with these expenses, because it seems like it obviously has been beneficial.
Yes, certainly. We will consider that. And as the governor continues to open up the state, we'll keep everything in mind and also take into consideration the staff members that are able to come into the office, the board members that are willing to come into the office. Once we get the okay that the building has been opened back up and we're allowed to come in and have more people in an office setting, then we will move towards that direction. But for now, unfortunately, we have to keep it more virtual than anything.
Good. Dr. Kearse,
yeah, I do. I want Ms. Capel to clarify something. If the governor's office was requesting 5% and our appropriation budget was $4.5 million, why were they requesting $370,000? That's closer to 10% of what our budget is.
Well, it was over the biennium, which is
2 years,
which is 2 years worth.
Right.
Oh, it was a 2. Okay. Thank you for the clarification. Okay. That makes sense. Thank you.
You're welcome. They did exempt the peer assistance. They did take that figure out. And so
I understand now. I thought it was on a yearly, so I didn't understand. Okay. Thank you.
You're welcome.
Any questions? So just to clarify, the board does not have a process or involved in the approval of the budget. Since this is a state agency, a lot of times nonprofits, the board approves the budget, but we don't have a role in that. That's because I don't remember us ever approving as a board the budget.
Well, that's where the legislative appropriations request comes into play.
Right.
We submit the base reconciliation where we ask for the minimum amount. And then with the LAR request, we ask for that minimum amount plus exceptional items, which we've asked for, which includes funds for the move. It includes money for our staff, those 4 exceptional items. So that's in addition to the base reconciliation. And that's what will be decided during the legislative session with Senate Finance and House of Appropriations.
Very good. So you brought up another topic.
Okay.
The move. Has that been delayed with this COVID and everything, the budget restrictions, everything?
Construction in the state, for the most part, has been considered essential. So the move, the construction of the building has not stopped. It has continued. We are in communication with the Texas Facilities Commission, where we submitted any additional requests that we had, and that's the money that we're waiting on.
Okay.
Or the quotes that we're waiting on. And I think what they're trying to do in order to save money is to gather all the information from all the agencies that are moving into the building and then be able to submit a quote to the proper vendors as a whole and try to receive that savings.
Very good. Board, any other questions as it relates to finance? Is that all that you have for finance?
Yes, sir.
Okay. Any other questions, board? Just a great job that you're doing. We appreciate all of y'all being down here and staying in the trenches, whether you're at home or in the offices. Appreciate all your work to keep us afloat and keep us protecting the citizens of Texas.
Thank you.
Very good. Licensing Division report, Ms. Mendez.
Good afternoon, board members. I have, sorry.
Go ahead.
Yes, sir. Sorry, I was making sure I got the camera going. Okay, so I have a few, they're just the same reports that are there. We have the anesthesia report, we have the CE audit report, and the division report, and then the quarter report. Notable thing that I do want to point out is that when we opened the renewals for the nitrous oxide monitoring standalone, there was 90. We've only had one registration or one certificate holder renew that certification. So it's just a reminder that if they don't renew, they're gonna, right now they're in expired status, and then next September, they're gonna cancel.
Wow.
And so
that might be a good thing to put out to our stakeholders through TDA today or the gatekeeper with this TAGD might be something for them. Yes, Dr. Henderson.
Can we put that in a newsletter?
Sure.
Thank you.
Great idea.
So just a reminder that these certification holders, they're neither a dental assistant or a dental hygienist. Okay. I do want to, I know we've talked about the assessment. It seems like it's like all we've been talking about, but I do want to say, give a big shout out to everybody who had a hands in on this. It was a lot of work. And it's our legal division, Dr. Bell, Jessica, who's the hygienist over with Dr. Bell, and Lee for their assistance in getting this together, and everyone working together as a team to accomplish this. So many, many, many thanks to all you guys. Thank you. Truly appreciate it. And then also I did want to mention that all our applications have been updated to meet all our updates, our fees, our anesthesia jurisprudence requirement for the anesthesia permit. So we haven't had any issues with those. And just wanted to keep the board updated with our processing dates. We're doing really well with our processing dates. I think I updated it, but I didn't update the report that's on there. So we were processing dentists and hygienists, and this is just for initial applications, December the 9th. And then for registered dental assistant, initial applications is December the 8th. And then lastly, I just wanted to remind everyone that our office is going to be closed for a week in December, the 21st to the 25th. And just keep in mind that this is a time that our labs and mobiles will be renewing. And so we actually sent out, with the renewal forms, we sent out a nice little reminder saying, submit this as soon as possible because the office is going to be closed and there are no grace periods. That's all I have. Do you have any questions for me?
Board, any questions? Dr. Henderson.
So I actually have two questions for you, Christine. The anesthesia inspections and your interpretation on the report that you have, we're still on schedule to meet our new license request or permit request, as well as catching up and meeting 313 in anticipation, even though we had that downtime of inspectors during the COVID time.
At this time, yes, we are. We might have a little more information in March. I don't think that we're ready to announce that today. I don't know. Okay.
And then my second question to you is, could you explain to the board your interpretation of the jurisprudence anesthesia exam and renewals as our permit holders and licensees renew their licenses?
Yes. So we try to make it clear on the website and on the information that we sent out. If it's not clear, we get some feedback, we can certainly update it. So a dentist, and one of the things that we just updated this morning, thanks to Dan, was our CE chart, where it says the dentist with sedation, how often they have to complete that jurisprudence. And so a dentist who does not hold a level of sedation is required to do the jurisprudence once every 5 years. A dentist who is just a general dentist with no levels of sedation, without a sedation permit, is required to do it once every 4 years.
Thank you. And so along those lines, and that's really where my question is, let's just choose me as an example, because I took jurisprudence 2 years ago, and the new exam for the jurisprudence that includes the anesthesia is now out and available.
Correct.
When do I need to take the anesthesia jurisprudence? This year when I renew, or when my jurisprudence expires in 2 more years?
This year when you renew.
Thank you. And I think that's what I would like for you to make a statement on. If you have an anesthesia permit, even though your jurisprudence may not expire based on what you thought you had, is that you need to take the jurisprudence this year when you renew your license, or the next time you renew your license, and then you're good for 5 years.
Correct. We've actually been getting those questions. We actually get a deficiency report of folks who renew online and enter in a date. So we've updated our Versa system to actually read, oh, Dr. Henderson is a sedation permit holder. He's not supposed to have it every 4 years. He's supposed to have it every 5 years. So we get notification of that deficiency on a report, and we then turn around and send letters out to licensees with this deficiency. Now, we do get the question where, like what you're saying, Dr. Henderson, is, oh, wait a minute, I did take that. Correct? You did take the dentist one, but we now have the jurisprudence, the anesthesia assessment available for you to take. And we haven't had any pushback. I mean, everything seems, we're just getting good vibes on it. So
good. Thank you. I just wanted it to be out in the public comment.
Sure. Thank you.
Thank you.
And I have Lee here if you have any questions for him. No?
Good.
Ms. Palermo.
Well, my question was, Christine, how are we following up on this labor and sex trafficking course? Is there a checkoff box on the application for relicensure now where it says you've taken it, and yes or no, or how is that working?
No, there is not. At this time, we are, if they're being selected for the audit as a continuing education audit, we are requesting that and requiring them to complete it, because currently our forms and the online, you check off the box and you're attesting to meeting the continuing education requirements for that renewal.
For everything. Okay.
Yes.
I will tell you, I just went through the license renewal process, and I attached my certification of taking that course and also the anesthesia ethics course as well. I sent both those certificates in.
Thank you.
Any other questions? So again, Ms. Mendez, thank you for your work. You're at the office a lot, so that you're making the trek in, and we appreciate you, your staff, and all the work that you're doing.
Thank you.
Dr. Bell, Legal Dental Division Investigations.
Yes, sir. Good afternoon, board. We have had, I put in my written report, essentially we've had an uneventful and productive quarter. All the numbers you'll find at the bottom of my report that I normally give you. The highlights would include, I just wanted to thank Jessica Menchaca, which Christine already mentioned had helped with the jurisprudence exam. But I would like to thank her for helping continuing to keep cases flowing to legal. With me filling both roles with dental practice and investigations, she's really stepped up and is doing a great job. On that same note, I encourage you all to utilize that DRP report feedback form during ISCs whenever necessary. And that will allow us to touch up training for DRP, as well as, if Jessica has let a case go through that it maybe needed a question asked to DRP or anything else, then we can get that addressed on that end. We do have one DRP mentee proposed for vote today. You can find those materials in your board member materials. Thank goodness this is a periodontist. We do have 17 cases in queue, waiting on our 2 periodontist DRP members to do. So having an additional member will be great. Actually, Drs. Yu and Dr. McNeil both talked one of their colleagues into applying. So one of them actually is the one you're reviewing today, and the other one probably will be ready for review at the next board meeting. So we're very appreciative of those referrals. We also have 22 cases waiting on an oral maxillofacial surgeon. So again, if any of you have any colleagues you feel would fit the mold for DRP, many of you were former DRP members, please send them our way, either through the website or directly to Jacob or myself. And we will get them going on the training. Be happy to answer any questions you have relative to the dental practice division at this time.
Dr. Henderson, surprise.
I'd like to make a motion that we accept the DRP mentee.
So we have a motion to accept the DRP mentee.
I second it.
Yes. Any discussion? Seeing none. If we could have a roll call, Dr. Kirsch.
Dr. David Tillman.
Approved.
Dr. Kirsch, approve. Ms. Palermo.
Approve.
Dr. Henderson.
4.
Dr. Yu.
Accept.
Dr. McNeil.
4.
Dr. Burke.
4.
Ms. Jones.
Approve.
Dr. Melcher.
Approve.
Mr. Bustamante. And Ms. Sisk.
Approve.
It was approved unanimously, Dr. Tillman. Thank you.
Any other questions for Dr. Bell as it relates to dental practice? Seeing none, investigations.
Yes, sir. I'm very proud of the investigations team. We're pretty much maintaining a input-output at the same level. Their caseload is creeping up a little bit. It was essentially rounded up to 9 cases per analyst in September, roughly 9 for October, and now it's creeping up to almost 13. So I think what's happened is there was a lull in complaints with so many offices being closed, and now we're kind of kicking back up to a regular number of cases, because of course there's always a delay in getting to the actual investigation process. So, I'm very hopeful that our request in the LAR is fruitful, and maybe we get at least one of the 2 investigators we lost back, because I think that will allow us to maintain the high quality and the productivity that we're looking for. Continue that out instead of getting bogged down with a great number of cases they're working at the same time. Again, despite that little bump, we are down to only 2.6% of the cases that they are actively working are over 75 days old. So that is just great. That means that our respondents are responding properly, our second opinion dentists are responding properly, our analysts are working hard, our supervisor is supporting them as needed. And that's just a great metric to see come so low. I think my Supervisor Melinda Heber really wants that to be 0. So we'll see if we can get it there. But in addition, she's doing just a great job. She's probably about 6 months in at this point, and she's just knocking it out of the park. So again, you can find all the numbers below that you're typically given, both when Charlize was the director and then now. So if you have any questions regarding those numbers or anything, I'll be happy to do my best to answer.
You're doing a great job, Dr. Bell. Thank you for.
Oh, well, thank you so much. We appreciate y'all's support.
Well, very good. Thank you, Dr. Bell. If we don't have any other questions, we appreciate your work. It looks like you've got home looking good and Christmassy back behind you, and hopefully you have a great Christmas and New Year's. Yes,
sir. Likewise to all of you. Happy holidays.
Thank you. Legal.
Thank you, Dr. Tillman. Legal division's statistics are included in your materials. I'd also like to mention that we recently hired 2 new staff attorneys to replace the staff attorneys who are no longer with the board, and their names are Carrie Bruner and Evelyn Hernandez. A handful of you have already met them at recent ISCs. Cassie and I are in the process of training them as well, and they're doing a fantastic job. We're very excited to work with them and hope to that you all get to know them better as you see them at upcoming ISCs. Our next set of ISCs are on January 7th and 8th and January 21st through 22nd. And with that very short report, I'm happy to answer any questions.
Any questions, board? Everything's running smoothly. Nobody has questions. That's great. Well, thank you. And all of your lawyers, our best to our new additions. I'm sure they'll fit seamlessly. It's great that we got the replacements there so quickly. So that's wonderful. Unless somebody has any other announcements, I don't have any announcements. Board, have I forgotten anything? Any announcements from the board? It's been a great meeting. Let me make sure I didn't forget anything. Do I hear a motion to adjourn? So moved, Dr. McNeil, second by Ms. Palermo. All in favor with your hands? I see a unanimous vote. I have 146. We are adjourned. Thank you, board. Have a great holiday, and hopefully next meeting will be together in person. But we will see you. Enjoy your holiday season and have a happy new year.
Merry Christmas to everyone.
Merry Christmas, guys.
Take care.
Great job, guys.
Everyone.
Good work.